Someone. Oh. Good evening, everyone. We welcome you all to the sixth series of Troubleshoot. We had on PCNL, RIRS, URS, transplant, urethroplasty. Now is the turn of TURP. And we have got six esteemed panelists with us. They are stalwart in their field, and we don't need an introduction for them. But for the for the completion's sake, I'll just give a brief introduction of all the panelists here. Dr. Arun Chawla, who is the professor and head of the department of KMC Manipal. He is also the co-chairman of Indian School of Urology, who is doing tremendous work along with USI for spreading the knowledge. He have got numerous national and international publication, and his main interest in minimal invasive surgery, endourology, and reconstructive urology. We have got Professor Keshavmurthy, who is the director in charge of Institute of Nephrology and Urology from Bangalore. He is also the secretary elect of USI. He have got several international and national publication, and his main area of interest is endourology and transplant. We have got Dr. Lalit Shah. I think he don't need any introduction, especially in this platform, Facebook platform. He is one of the most active member. He is the director of Jagjivan Urology Center, Raipur, and he is the president of West Zone USI. He is one of the few urologists who have got dual degree LLB in medical legal, and he helps almost everyone in guiding in case they are in trouble in medical legal aspect as well. He has delivered many talks at various conferences. His main area of interest is TURP, urethroplasty, and gynecological fistulas. We have got Dr. Anant Kamath, who is senior consultant at Cord Hospital, Bangalore. He is the former professor and head of the department, Bangalore Medical College, and also he was medical superintendent at Nephrology Unit, Bangalore. He has got several publications under his name, and his main core interest is in endourology and reconstructive urology. We have got Dr. Girish who is a senior consultant urologist at Sakra Hospital, World Hospital, Bangalore, and Dr. Anurag Yadav, who is a senior consultant urology at Puspanjali Hospital. His main area of interest is endourology and reconstructive surgery. With me, Dr. Aditya, who will be moderating the session, who is a senior consultant at Apollo Medic Super Specialty Hospital. He is one of the earliest to start supine PCNL in India, and he have got several national and international publication under his name. I am Dr. Nitesh Jain, and with this a short introduction of Ulte to all the esteemed panelists and viewers. We started actually in the year 2015 June. The main aim of this platform is to spread knowledge beyond boundaries. Today we have got close to around 6,400 members, mostly urologists from nearly 100 countries. We get more than 250 posts in a month with 10,000 reaction and 4,000 comments in a month. We were the first early in the era of virtual conference. We started even before the pandemic started. And we can be easily searched on Facebook as Ulte. With us is Euro Academy. We do almost all program hand in hand. They started in the year 2019. This is a website based, and it is dedicated to esteemed teacher Professor Venugopal and Dr. S.S. Joshi. It is in line with famous Euro education, which have shaped and boosted the knowledge of many current generation urologists in India. And many senior faculty who are not comfortable with social media probably can access www.euroacademy.org. So this is the team, Dr. Anil Takwani, who guides us, myself, Dr. Tanuj, Aditya, and Rahul. Just a disclaimer, many of the scenarios are hypothetical and we may not have any representative images, but such situations are often encountered in day-to-day clinical practice. The objective of this session is how to bail out of a given situation, not the management of case. Please pardon us in case we interrupt any panelist in between, as the time is limited and we are looking for to the point answer to discuss maximum scenarios. Some scenarios are peculiar to procedure and not to point. We intend discuss alternative procedure, request not to suggest other options. Few questions may be to know how the panelists practice rather than actual trouble. So let's begin. So we'll start with the pre-op thing. The first question is to Dr. Keshavmurthy. Sir, what is your practice of TURP on a patient on antiplatelet? Suppose he is on a aspirin. So how do you go about?
See, you have to see whether this patient has been put on antiplatelets just for prophylaxis. A lot of people are now on prophylaxis. If that is the case, then I would ask him to stop the antiplatelets 7 to 10 days prior to my procedure and do the procedure. But if the patient has got a bare metal stent or a drug-eluting stent and requires to be on antiplatelets, then we will have to consult this cardiologist and find out whether he can be discontinued. If it is not possible to discontinue, I would continue with aspirin, stop his clopidogrel, and then a day or 2 days prior, we'll do the bridge therapy. Due, uh, Prior to the procedure, we'll start him on heparin. We use 5,000 units heparin and continue that for 24 hours. Later we stop heparin, and once the hemostasis is all right, then 3-4 days later we start him back on aspirin. That's our practice.
What about dual patient on 75 and 150 gram both? You will stop or only
if
on
the if the patient has got that he needs to take one of the antiplatelets because he has got a stent inside, then we would, if it's 75 aspirin, there's no problem, we continue with aspirin. But if it's 150, then we resort to bridge therapy.
What about clopidogrel and the newer antiplatelet?
Clopidogrel, I would definitely stop, and warfarin also for that matter. We would definitely stop and then use heparin because it's easy to reverse if there are bleeding or something with heparin rather than clopidogrel or other newer antiplatelet drugs.
So for the panelist, anyone else who is not stopping antiplatelet prior to TURP, monopolar TURP? Any panelist? This question is open to anyone.
Like 75, we do not bother to open.
Okay.
But for other things that we do stop. For 75, we do not bother.
So I think everyone
until it is a very large gland.
So I think everyone agrees that we need to stop antiplatelet prior to surgery at least 5 to 7 days, and 75 we can, if the gland is not very large, probably we can avoid stopping it, but 150 and a dual platelet and the newer one we need to stop. Newer one probably 2 to 3 days is enough. In case patient is on anticoagulant like warfarin, a bridge therapy like heparin, we can switch over to heparin and we can go about. So we'll come to the next scenario. Aditya.
Yeah. So in pre-op scenario, sir, my question is to Dr. Lalit Shah, sir. Do you think that it is always mandatory to have a pre-operative culture than to have a pre-operative sterile culture?
See, in an Indian scenario, on the practical basis, it is not being done. What is being done is, in general, that the patient is admitted and he is given an antibiotics, injectable antibiotics for 24 to 36 hours, and then the patient is taken for surgery. And meanwhile, the urine culture has already been sent. If the result comes in a different way, then the antibiotic is changed. That is the usual practice. Theoretically and ideally speaking, yes, you should have an sterile culture before the surgery. That is a different thing.
Sir, Dr. Kamath, sir, what one should do if, despite all attempts, the culture continues to remain positive and we fail to have a sterile culture before?
Distribution comes in a catheterized patient most of the times, or patient has got other problems. So, if the culture does not become sterile, I would cover him with appropriate antibiotics and continue with the surgery. I mean, we would take, but always caution the patient that it is likely that he could get into problems like sepsis and all that. That particular issue has to be highlighted because that is a possibility.
So, how many days antibiotic cover you prefer?
48 hours.
48 hours.
Before the procedure.
And in the same scenario, if the culture comes out to be resistant to almost all the drugs available, and many times we see sometimes only colistin, and now we are seeing colistin resistance also. So in that scenario, what is your suggestion?
Then you put him, you repeat the culture at another place, which is very unlikely that all antibiotics are resistant. So you repeat the culture after some time or at another laboratory. And if that helps you to get it to a sensitive antibiotic, that is okay. Otherwise, you take the risk and you cover them with a broad spectrum third generation cephalosporin and then go ahead.
Thanks. Anyone else want to add anything, please?
I would like to say that we usually do not do a urine culture. Leave aside being trying to make it sterile, we don't usually do a culture unless there are lots of pus cells in a non-catheterized patient. In a catheterized patient, again, it's likely that the culture will be positive and you will not be able to make it sterile. So we go ahead with URP unless the urine examination shows full of pus cells. If there is full of pus cells, then we start with the preoperative course of antibiotics. Otherwise, antibiotic immediately before the operation is sufficient in my practice.
Dr. Yadav, actually correlation between culture and pus cells is not there at least in 25-30% cases. You may still
Yes,
have a
maybe,
culture.
yeah. But I'm still practicing that if the pus cells are only 1 or 2 or 5, we are not ordering culture and we are not giving any course of preoperative antibiotics.
Okay.
We do cultures and give a course of antibiotics only while removing the catheter, not on a patient who is in a catheter and is going for QRP. Again, if the urine is opalescent and visibly purulent, dirty, then of course we would like to treat it. Maybe sometimes even with the betadine instillation, 1 ml in 10 ml of distilled water, instill and keep it there for 5 minutes and leave the catheter to drain. That is one way of making the urine little sterile.
Dr. Girish, you wanted to add something?
Yes, I would like to speak. This is regarding the positive urine culture which is resistant to all antibiotics. Yes. Hello?
Yeah.
Yes, sir.
Yes. When the question was what happens if the urine culture is positive but resistant to all the antibiotics? The answer is you don't have to bother too much about it. You use the antibiotic that you use normally in your hospital practice. Because nowadays meropenem and colistin resistance has become very common and you are at a dead end and you can't do anything. But you use an antibiotic because we know that in vivo and in vitro sensitivity are not the same.
Before you ask the next question, I would just like to add that to have urine culture would be more medico-legally safe.
That's true.
Whether it is a pre-operatively, whether you get it sterile or not, but at least one culture report and the documents would be very helpful in case of medico-legal issues if it occurs.
Point well taken.
Dr. Chawla, my question to you is, do you think this difference of practice lies between an institutional practice when teaching institute practice versus a private practice, or in that kind of practice, things are work very differently?
Yeah, obviously, institutional practice, we don't worry about the pre-operative number of days the patient stays before he takes the surgery as well as the post-operative. And we have time to give the adequate operative care to this patient. Coming back to your question of the culture, if you say non-catheterized patient, it may be a routine to send the culture to all the patient who goes to the OR next day, but usually the reports are fetched during the time of discharge. It takes 24 or 48 hours for these patients to for us to get the report. So that means all patients get operated for TURP in the absence of culture report before procedure. But culture report before procedure will be needed in patients who are catheterized. In catheterized, you were talking about the antibiotics not becoming sensitive. Again, the point is in vitro, in vivo, the sensitivity may not match each other. But so far, as we are using a third generation broad spectrum antibiotic, that will be good enough unless and until patient becomes symptomatic, or you have come across a patient where on operation you find that there was an abscess.
Thank you, sir.
So we'll go to the yes, Dr. Kamath, sir.
Yeah, I just want to insist that if you take the history very well, if there is any suspicion that patient has got not only obstruction but associated urinary infection, you have to pay particular attention to these patients for urine culture and sensitivity and try to make them sterile, whether catheterized or non-catheterized, because these are the patients who are likely to get into septicemia and then post-operative complications.
So we'll go to the next scenario. We get this question is for Arun sir.
Yeah.
We see lot of patient with hernia and BPH. So can we do both the surgeries simultaneously?
So what has happened? This situation we have faced many times, and usually these are the patients who come from surgery and they are referred to us for urology consultation, and then we examine this patient and you stress the flow rate history and all that. They have poor IPS score, flow rate very reduced, and all that. And that's how the combined approach between the hernia, this general surgeon and urologist become mandatory. What we do is a gland which needs resection up to half an hour to 45 minutes by surgeon. That will be good enough to finish TURP, and along with that, the general surgeon will chip in to do the procedure, which is usually nowadays is mesh herniaplasty. We'll not do this procedure as a joint procedure that we're doing simultaneously when this gland is very big and we know this procedure is going to be for more than an hour or so.
So why
That time we are going to stage.
why you will not do in large gland combined procedure?
We expect this patient because you have to see the anesthesia has to be planned according to the duration of the procedure. So when anesthesia people ask is how much time you are going to take, you are talking about your TRP part. So I need 60 minutes, I need 60 minutes plus 75 minutes. But if you have to plan a hernia along with that, it needs much more time. So that means first you have to plan your procedure, then that. So it's just to avoid. You can easily stage it to not to add any extra morbidity.
No, we can always do it under epidural and we can extend the anesthesia. So gland size, will it matter?
No. For us, that's how we do.
Okay.
Yeah. So we won't do a large gland with a large hernia. We'll do a moderate sized gland where we can finish the section, and hernia people will come in and finish that. And same happens to the surgery side also. If they have a sliding hernia or a very complicated hernia where they think is going to take much more time, they will also like to finish our procedure to go first, and then they will do their procedure in the second stage.
Dr. Keshav, you wanted to add something there?
See, there are some surgeons who are apprehensive of doing a TUR simultaneously with the hernia, because if you have the resection time around 1 hour, something more than that, and the gland size is large, they have found that when they open for the hernia, they found lot of fluid, because you may not have extravasated intentionally, but there is still some amount of extravasation which happens if your resection is for a longer time. So there are surgeons who ask that you finish the prostate, we will do hernia at a later date. So there is some apprehension. There is going to be some fluids if the resection time is going to be longer. There is some fluid when they open up for hernia. So they will be apprehensive putting in a mesh at that point of time.
Yeah, this I like to just confirm with exactly Dr. Keshavmurthy's observation. If we see that this resection is done by some resident and you take it later and you explore this patient with inguinal incision, you will see the edematous fluid coming when you come across the fascia transversalis. So this is all because of the thinning of the capsule, which you think you have done correctly. It is usually at the bladder neck, the sieve-like openings will be there and fluid extravasate. This we have seen in few situations like that.
Sir, I would like to share one scenario on account of my surgical friends whom I've discussed this thing. They said that mostly we are not bothered much when we are doing open hernia surgery and mesh, but their concerns are really high if they are doing a laparoscopic one. So their point is the laparoscopic surgery is lot is on stake because that came up later. So they are more cautious in laparoscopic rather than open hernia surgery.
See, again, Aditya, the question will be, what happens is how surgeon look at. If they get a bilateral inguinal hernia along with the TURP, what they will say, they will ask us to finish that and then they will stage it and put a laparoscopic procedure and put mesh on both the sides. If it's unilateral, then probably it's the same scenario which we have discussed earlier, whether to do in the same sitting or little later.
So anyone wants to add anything there? So what we understand from, yes sir, Kamath sir.
Chronology is important. Always TURP is first, because they do not want any contaminated field around when after the surgery is finished. Water spillage, that is one point. And I hope the decision to do a hernia surgery or not along with prostate, I mean as an indication. There are occasions where you can leave the hernia alone. He is not. There is a hernia is to be done. They will send a reference for prostate. Whether TURP has to be done along with that, that's a
No, it is purely indicated. Indicated surgery we are talking about. We are not.
Hernia first, and we always do simultaneously and along with epidural anesthesia. I had no occasion to do it on two separate sittings.
Sir, especially with the sterile urine culture, should it even be a concern that much? Because time limit is really, arbitrary understanding. At 1 hour it will not happen, and half an hour it will not happen, and at 1 hour it will happen.
No, you will have to be careful in your resection. That is all. You will have to be careful in your resection when you are doing this simultaneously. It is an apprehension that when they are putting a mesh, if there is some amount of infection, they are going to get into trouble with hernioplasty.
So with this, what we understand is we can do hernia with TURP together, but there should not be any extra vessels. In case we find we have breached the capsule or bladder neck, then probably better to avoid simultaneous surgery. And it can be done safely, and we have to plan the anesthesia accordingly. So we'll come to the next scenario, Dr. Aditya.
Yeah. So another condition pre-operative which comes very commonly seen is the pacing devices which are used in cardiac arrhythmia patients. So how does one should go about it? And I would like to ask my question to Girish sir, if you.
Yeah. Usually, it is not safe to do a TURP when the patient is on a pacemaker without adjusting the pacemaker. Okay. Without changing the pacemaker setting.
Okay.
And, hello?
Yeah, please, sir.
Sir, you keep your phone off. Go, there is echoing there. You have to keep one device off, sir. Girish, sir. Probably he's not there. We can move to. We can move.
Dr. Lalit Shah, sir, your opinions are on this?
We have to take care, but it can be done.
So
what? Yeah, Dr. Girish is back. Actually, we could not get your voice, sir. There was echo was coming, Girish, sir.
Now how is it okay now?
Actually, okay. Yeah, please, sir.
Yeah. So what is the best we call the person who is on?
No, not
I think
audible.
it's helpful.
He's using mobile.
Aditya,
We'll sort it, sir. Just okay. We finish this scenario, then we'll sort with Girish, sir. Yes, sir. Keshav, sir, you're saying.
See, the pacemakers, we generally encounter these very commonly. It all depends on for what condition this pacemaker has been put, because there are different indications to put these pacemakers. There are something called as demand pacemakers. That is, it will act only when the patient has got an arrhythmia or something. It will recognize and then the pacemaker will be used. Or there's something called as fixed rate. That is for patients who have very severe bradycardia. They will fix in their pacemakers at certain rate that it should be. So it will depend on for what reason this pacemaker has been placed. And once you know the pacemaker is there, you will have to ask the cardiologist for their opinion, and the technicians have to be in the theater to adjust it, because the pacemaker can be adjusted so that there is no cardiac arrhythmias because of use of your diathermy. So, or some people, they say, I have not seen anybody placing a magnet, but that's what given in the literature. But I have done a few with the technician being there. They will be able to adjust the rate so that it does not, and even if there is a problem, they will be able to manage with the pacemaker. If you should have the pacemaker technician in the operating zone. You will have to place the patient plate far away from the pacemaker. Better to place it onto the thigh or not close to the chest. Some people are in the habit of putting it at the back. So you will have to, and the way you can prevent it is the people now use bipolar, but it's only a discussion on monopolar.
Yeah. So this is only about monopolar. So what we
See,
understand.
one of the very important thing that we need to take care is that there is no breakage in this line, because if the earthing and all these things are not proper, the current will go through that. Otherwise, the current is not going to go through that. Earlier in our practice, we have done quite a few, but now since a few years, we do not do it where we do not have an ICU and a cardiologist available.
So what we understand with this discussion is that, of course, monopolar TURP can be done with pacing. After changing the pacing, they are mostly intermittently firing pacemakers. So they are paced to the continuous firing. And after doing that, with due fitness from cardiologists and help of technicians, it can be done. The path has to be shortest. The current follows shortest path of least resistance. So we have to see that from entry point, because you are working in lower track, the current should have to travel least amount of distance till it reaches the plate. So it has to be closest under the buttock maybe, or under the thigh. And of course, the precaution, the surgical time should be as less as possible to reduce the risk. Dr. Nitesh, yeah.
So we have seen the pre-op. Now we'll just go to the anesthesia part. Suppose we are having a patient who is high risk for general anesthesia, and the spine is very stiff. Your anesthetist is not able to give a spinal. So how will you go about? And the question is for Kamath, sir.
I do not know. I do not know how. You mean the patient cannot be positioned for the.
No, he's not positioned, sir. His spine is stiff. They are not able to give a spinal. The spinous process, everything. They are not able to give a spinal anesthesia, and is very high risk for general anesthesia. So can a TURP be done under local anesthesia or a caudal block, something of that sort?
Even caudal block also requires the same issue will be there. But I do not know. I have not done anything in local anesthesia. But there may be other procedures other than TURP, something like injecting alcohol into the gland so that it necroses a little later if the patient is so much unfit.
Arun sir, do you want to offer anything?
No. I think we have not seen many situations where they were unable to put anesthesia, but usually they will have some lateral block, something like that, to encounter the situation. And probably if he's high risk for GA, you have to wait for another day when he seems suitable for another try by the anesthesia.
Dr. Girish, you wanted to add something?
TRP should, we should not, it should not be advocated that TRP should be done under a block or a local anesthesia. It is a procedure which needs resection, and epidural, regional, or general anesthesia are the ideal anesthesia choice.
Dr. Girish?
Hello?
You unmute, sir.
Unmute yourself.
Such a situation should never come, because pre-operatively, when you assess the patient, we know that the anesthetist is going to face problems. So the anesthetist will have to do due diligence and ensure that he will be able to access the spine or even the epidural or give epidural. But on the other hand, if there is no way, if the patient has got such severe spinous problem, then he should be at least fit for general anesthesia, because we should not discover such things on table. We should deal with them before the surgery itself.
Many times anesthetists, they go in with a belief that, okay, fine, we'll be able to give anesthesia, but they fail in OR. It happens at times. So we are discussing.
Yeah, for example, if the anesthetist anticipates a problem, if he has seen the patient before, he would be ready for general anesthesia also. The problem comes when the anesthetist feels that he will not be able to give a spinal or epidural before surgery.
and he also feels the patient is not fit for GA, then on what basis can we take the patient for TURP, or on what basis can the anesthetist accept that? That is, I think that situation probably will not be able to do TURP at all.
Dr. Anurag, you wanted to add something
Yeah,
there?
I have not faced such a situation, but I can just guess what will I do if something comes like this. I like to do a paraprostatic block. I usually give paraprostatic block in all patients of prostatic biopsy, and the patients have no pain at all. I take 12 core biopsies, and patients have no pain. So paraprostatic block works very well. And if such situation comes, then I would like to give a paraprostatic block.
Yes, Keshav, sir.
See, doing TUR in a caudal
Yeah,
block or
agree.
local is very difficult, is because you may block paraprostatic, but the bladder distension is going to be there. So if you have to have a good spinal anesthesia, you should be able to block T10 till T10 at least. Then only the patient will be comfortable. If you are trying to do under local, the patient will have discomfort because of the bladder distension which is going to happen. So it's not easy to do
It's not easy.
under blocks, because the bladder distension part will be there in these patients.
Yes, Arun, sir, you wanted to add something there?
No, I'm just what Dr. Keshav is emphasizing. Same thing I'll say. So you can resort to shorter procedures like you are doing VIU under local anesthesia. It's the same way. People have used doing shortcut to TRP when the patient is not fit. This is giving a cold incision at 12 o'clock, giving rise to anterior commissurotomy, giving with a cold knife incision and all that for a temporary. But TRP, no, which involves the section of the prostatic fossa and the distension of the bladder, and it needs a continuous irrigation. Yeah, difficult.
So, but there are few literatures available where they have done under pseudo, like pseudo analgesia.
Yes, you can.
Yes.
And some local there, and they do it.
Yeah, case reports are there, series are there. Yes.
Yes, sir.
Yeah.
A common scenario is there when mostly in cases of CA prostate and patient has spinal mets. So not because of failure of anesthesia, their anesthetist is very concerned about entering that area because the vertebral column metastases are there. And if the patient, one case we had, but luckily we could take high risk consent and do it under GA. But that was one case where spinal was out of question and we had to do TUR. Channeling.
And I'll add just a little bit to what Aditya is telling, but at the same time, we have scenarios where patient is taken for TURP and within 10 minutes, the spinal fact is over. So then you have no way. So, and the patient initially, they have thought this patient is not fit for GA. So it's the same scenario. There, our anesthetists have used their, what you can say, diligence or wisdom, where we have finished as early as possible under mask and a little bit of sedation and all that. These are also scenarios we have seen.
Repairing of the spinal.
Within 10 minutes, probably 15 minutes, but the gland is not even 25% resected. So, but there also we have not gone for a full section. It's tied over the situation and come out and wait for another day to go in. Yeah.
So to conclude, what I believe is ideally a TURP should not be done if a patient is not fit for GA or spinal, and probably we should refer the patient for some other alternative procedure. In case the spinal wear, so probably we can give some sedation and we can finish up the procedure as fast as possible.
Sir, if spinal wears off so early, 10-15 minutes, we can give spinal again. I mean, there is no reason that one should not.
No, Aditya, spinal means the gland is bleeding. You can't secure hemostasis. So you have to put again for attention. Yes, definitely, yes.
Dr. Aditya.
Yeah. So again, after anesthesia, the next step is the positioning of the patient, and we have seen all kind of difficulties in terms of correct position of the patient. So, Kamath sir, what is your opinion if you are not able to give lithotomy? How much window one really needs to enter and finish the procedure?
The preoperatively, one of the important things whether you will be able to position the patient is whether the patient is able to use an Indian closet. If the patient can squat and use an Indian closet for defecation, that is you can be assured that you will be. But if you have obvious difficulties in positioning, you should be able to get at least, again the decision is on the size of the gland. If it is a very big gland, it is going to take a lot of time, and you have a very compromised position. If it is due to spasticity, due to muscle problem, then it is not big. But if it is an orthopedic problem where there is fixed deformities, if you can get enough room for you to accommodate between the legs and access, then it is fine. Otherwise, if you cannot do that, then one of the ways out is to go through the perineum. You go through the perineum, do a perineal ureterostomy, and through the perineal ureterostomy, you will be able to do a TURP.
The TURP in, Dr. Yadav, TURP in lateral position like we do through perineum, is it a possibility?
I don't think, and I have not faced such a problem. In a very difficult, rigid position of the hips, I would refuse TURP, and maybe open can be done. But a very small prostate and a short procedure, and you can struggle for 10 minutes, give some incision and something, and you can get away with that. But perineal ureterostomy and doing the procedure, I think is same. Doing a urethral TUR and a perineal TUR, same instrument, same position of your hands. I don't think it will make the life easy.
Because perineally one can access even in lateral position. I mean,
yeah. Lateral I have never tried. Never seen anyone doing it today.
So to conclude on this point, the position is very important aspect of TURP surgery, and one has to ensure in his OPD room that patient can be adequately positioned, especially at the time of examination by flexing his legs. It can be seen, as like Kamath has said, usage of toilet also gives indication. So next.
Dr. Girish, this question is for you. Suppose you encounter a patient with a very narrow meatus and there is a large gland, and you are going to do TURP. So what is your preferred way to dilate the meatus? By Otis, or you will do a formal meatotomy?
Yeah. See, before I answer this, I would like to just make a reference to the discussion we had about the previous 2 points. One, what if the patient is not, spinal is not possible and he's not fit for GA? And the second is the positioning. I think in both these scenarios, we should never find ourselves in such a position where we have to discuss this at all. So that's why pre-operative evaluation is so important.
So
and coming
what
to the
happens, many of us actually, many viewers are freelancers, and they go to the peripheral hospital and they find themselves in difficult situation at times. So we are just discussing, taking all the common scenarios.
But it's all the more important for freelancers, because ureteroscopy, you can do a surgery without even seeing the patient. But the TURP, as far as I am concerned, is a physiological surgery. Ureteroscopy or a PCNL are anatomical surgeries. A physiological surgery should never be done unless we evaluate the patient properly. That's why all the more important why a freelancer should be very diligent about these 2 things: a freelancing anesthetist as well as a freelancing. Anyway, that's what I feel. Coming to the present question about the meatal stenosis. I mean, again, I would, I always do a physical examination in the OPD, anticipate meatal stenosis. And the second thing is, in case I find that the meatal stenosis is manageable, I use a conical meatal dilator just to dilate the meatus and enter, or else I use a knife to make a dorsal cut.
Voice is gone.
So I dilatation or by a dorsal incision, one of these.
Dr. Kamath, sir, yes.
Yeah. When there is a meatal stenosis, I will go in the preoperative session itself, go beyond.
So it's not very significant. You find meatus okay pre-op evaluation. Only when you are inserting a 22 French sheath, you are finding it difficult. So what you will do in those cases? Sorry, sir?
Dorsal meatotomy. I do to cut the glans dorsally, not ventrally.
So you will use Otis, or you will do a formal meatotomy there?
Formal meatotomy.
formal
And
meatus.
only when if the urethra is not accommodative, then I will combine it with OT.
Any other panelist will differ with this?
I sometimes we find even with dorsal myotomy, the instrument is not going. Then there's no harm in giving a additional ventral myotomy and don't stitch it. Leave it open. It will not cause uh, stenosis or hypospadias. So you can give both dorsal and ventral myotomy to make a large meatus and put a knife inside and cut from inside like an internal hysterectomy uh, at the 12 o'clock, because sometimes this stenosis is the whole thickness of glans. It is not the meatus, but the glans is small and the subglandular submeatal area is also very tight. So keeping a large sheath in a tight meatus for long will not be good. So cut with a knife introduced inside and cut retrogradely backward outside.
In my opinion, I am really against the dilatation. Actually, 3 of my patients where I could accommodate scope after dilatation, but they did have meatal stenosis after a few weeks. So I think cutting is always better than just dilating, because even if we force enter the resectoscope in, that is also a dilatation. May not be a sequential one, but in my patients it has caused problems.
No, even with Otis also you put a cut there.
Yeah.
The cut is always better, no denial about that, because the per se is not very good. In such patients, what we are doing in addition is later on post-operatively patients, we give them so as to do the self-meatal dilatation.
Keshav sir, what are your tips to prevent meatal or submeatal narrowing in post-op? We see a lot of patients actually, and quite a few patients having meatal stenosis after TURP. So what are your tips to prevent that?
No, you'll have to call him for when he comes for follow-up. We have to look for, because this is the commonest stride for a post-TUR stricture. The submeatal and the fossa navicularis strictures are the very most common ones, and this is one of the reasons why the patient will present to you with all the problems that his flow is not very good. Even after a TUR, a good TUR, you'll have to evaluate whether he has got a submeatal stricture, and if it is so, then if you are suspecting that this patient is going to, I would advise self-dilatation for some time.
Yes, Kamath sir.
In general, I would like to say that the instruments that we are using, this is a general rule, that instruments are smaller, they are big for the Indian urethra. So many of the senior urologists with whom I have interacted, they say that the size of the instrument is bigger. That is why these pictures are there. So one of the ways out is to use a smaller resectoscope or use the inner sheath with a suprapubic. One of the senior urologists who does TURPs, many TURPs he has done, he says that he routinely uses a suprapubic catheter, that is a specially devised catheter for outlet, and uses the inner sheath of the resectoscope only for TURP. With that, his stricture rate has drastically come down, whether it is in the bulb or it is at the submeatal stricture. So this is a general rule.
Yes, Arun sir.
Yeah, so coming back to the same, I will agree with Aditya's comments that giving incision at the dorsal part of the urethra will be good if you find a metastenosis. Only thing is bleeds a little till your sectoscope stays in for some time and it automatically seals that. Second is coming to Otis urethrotomb versus using Clutton-Bougie. Not many people are using Otis urethrotomb now. Now we are talking about currently. And other thing is, when if you have to use not to use Otis, it's better to take a urethra dilator or a Bougie or Clutton and see if you're using 22 or 24, at least 2 to 4 French more than that, your dilator should go at least comfortably in the Pender's urethra without any catch. So you should go freely and it should come out freely. So that will give a space around the sectoscope, which will not cause postoperative strictures. Again, the principle of using orthourethrotomb is same, dilating the urethra enough, at least 4 French of more than the size of the sectoscope which you are choosing. And some people use it with a knife, some people use it without blade also. I use metal bougies only for pendulous urethra. I don't take it full and put it blindly inside, just to see the adequate first the meatus, if it's capacious, because sometimes you don't know if meatus narrowing is accompanied with the urethral caliber also is affected. So just a gentle bougie with a nice jelly of pendulous urethra. If 26, 28 goes, that means my 22 or 24 French cap will be good enough.
I would just like to add one thing. Number one, that it may probably not sound very practical or everybody may be following that, but I am using only and only exclusively inner sheath. I'm not using continuous stethoscope. I can understand that most of the people will not be this comfortable with this idea, but that is what we helps in reducing the stricture rate. That is point number one. And number two, sir, some read about using the bougies, which are blind things. I always use the visual obturator to use that, because maybe I am not that very confident to use the bougies. So I do not have the metal dilator in my nursing home at all. That
Sir,
is just a different thing with that I have.
Sir, only inner sheath usage is possible if we have a non-rotating dissectoscope. Using only inner sheath is not an option with the rotating dissectoscope, which is the most common one being used now.
That is what I'm saying. I have all sets of stethoscope available with me, and I use that.
Probably we can do only in small gland. Whatever large gland, it will be difficult to use.
See, even in large gland also, I am using the same one, but then I add in suprapubic there.
Okay, fine.
I would insist that our urethras are small. We would accept that and then adopt ourselves. This will be a very, very safe procedure to use inner sheath only. An additional investment in a inner sheath is not a big issue. And use the suprapubic catheter for drainage. Slowly, if you adopt this strategy, this you will realize only after 20, 30 years of practice, and you will find that at the end of that, you know that your stricture rate is going to come down. So this fact we have to accept, that Indian urethras are small for the instruments that are made. And if you use a smaller receptors, your resection time increases. That is a disadvantage of a continuous irrigation, smaller receptors. Chips are small.
With this, what I understand is ideal. We should have a pre-op assessment of the meatus before, and we should plan accordingly. It's always better to do a meatotomy or a formal cut rather than dilating the meatus. And the sheath, there should be a difference of around 4 French between the meatus and the sheath. And in case meatal stenosis is one of the most common cause of post-op decreased flow. In case if you are suspecting, probably we can ask the patient to have self-dilatation in post-op period. And it's always ideal to have a smaller sheath or inner sheath, especially for the Indian urethra. So we'll go to the next scenario. Aditya?
Nitesh?
Sir?
I don't think we have not touched about the point where is a gland is large and you can't use smaller sheath. Somebody wants to go in via perineal hysterostomy.
So we'll be coming, sir. We have got 50 scenarios, so we'll be coming to each and every.
Yeah, okay.
We'll be coming there, sir. Aditya?
Yeah, so about urethral dilatation, my question is to Dr. Keshavmurthy, sir. What would be your preference of choice, Otis, Clutton, no dilatation or selective dilatation?
No, we have both Otis with us, we have Clutton, but I am used to using a Clutton's dilator. I am very comfortable using a Clutton's dilator. If I have to calibrate the urethra, I use, but Otis is also a good modality, but you should be using it regularly and you should know how to use it properly. That is all. Both Otis is much better because you have a very clean cut. You have a very clean cut, but Clutton's, the disadvantage is a blind procedure, but you should know how to use it. We are very comfortable doing with Clutton's dilators. It's not a problem.
So do you do dilatation in all the cases or you do selective dilatation?
No, I don't do dilatation. I will try to calibrate the urethra if I find that the urethra, suppose there is a meatal stenosis and you are making a dorsal cut, then I will try to put in a Clutton's dilator to see the rest of the urethra is all right before I go in. Otherwise, if my scope goes in with the visual obturator, we always use visual obturator. If it goes in without any problem, I don't require to do any dilatation.
Yeah, Kamath, sir.
No, we have to differentiate between two things. One is meatal stenosis, which is pathological. and you have to squeeze with a smaller meatus. These two things are different. If you see meatal stenosis, which is a pathological, you always be careful to use any blind instrument because there is likelihood that you can have picture elsewhere in the urethra, and a blind instrumentation is not correct. And in this, with meatal stenosis, more preoperative assessment is always warranted. We should not have surprises on the table.
I think we should de-link the meatal stenosis, which is something like a disease, which itself is responsible for giving flow rate and symptoms, than the prostate symptoms. So we are talking about, I think, Nitish is asking about a meatus which is not adequate. Am I right?
Yeah, I mean, the meatal, I missed your voice in between. So.
Small meatal.
So we are discussing the meatus, which is
So
not
meatus
adequate.
is over. So now we are coming. So many
You-
people actually do routine dilatation of the urethra or calibration of the urethra. So in case if you are doing dilatation or calibration, what is your preference? Whether you will use Otis or a Clutton or any other, or you use it selectively? That's the question now. Not about meatus. Entire urethra we are talking about.
No, I was answering Dr. Kamath that
Okay.
meatus should be. My point is we have to be clear whether it is inadequate meatus or acquired disease, because meatus stenosis itself give rise to symptoms which are looking like a prostate symptom. We will have, so we are delinking that. Now coming back to what you have asked, Otis and the Cluttons, I think I totally agree with Dr. Keshav. I follow the similar principle that the Clutton's bougie, you should know how, the art of putting the bougie. Again, we are not putting these Cluttons into the whole urethra and into through the bladder neck into the bladder. It is just the calibration of, especially the Panelist urethra. It goes along the floor, and a caliber is assessed, and you come out. So, and while you are coming out, you assess the catch. That is more important.
So I think many of the younger urologists, they are missing the art of inserting a Clutton's urethra. What I feel. Uh, Lalit sir, what is your comment on that?
Yeah, see, what is important is that everybody must know what they are comfortable and confident with, and that is what they must practice. If they are not confident about putting up this one, the blind things and all that, then it is much better that they put the visual obturator.
Sir, I think why the younger ones you said are not doing, because the time is moving towards more visual feedback. I mean, everything, if we don't have Otis and we find the urethra is narrow, I would rather do a clean cut OIU under visual scopy rather than doing a blind dilatation. So I think that may be one reason one may feel so. Yeah, Dr. Yadav.
Yeah, I use Cluttons in all cases, and as Dr. Keshav said, for calibration purpose, not for dilatation purpose. And I don't start with dilatations. I start with cystoscopy. So I visually first see, especially in those patients who are not catheterized, that everything is fine, and also assess the bladder and everything. Then I pass Clayton's bougie, which is a blind thing, and it should be, of course, as is an art. So I have no problem in that. And I pass up to 28 French. But it should not be forced. It should not be used as a dilator. If it is not going, then it is not going. And then I use Otis. So for meters, I make a cut. For rest of the urethra, I use Cluttons for calibration, as Dr. Keshav said, not for dilatation.
If there is a message for younger urologists who are not used to dilators, the dilators can cause a lot of problems. So I think better you use something under vision. You first do a cystoscopy with a smaller cystoscope, and then you will have a fair idea as to what is the urethra can accommodate. And then pass the regular cystoscope with a visualizing obturator. If that is fine, there is no problem. Then you can use. There are dilators with a which can be passed over a guide wire. You can first pass a guide wire, and their perforated curtains are available. You can use them for dilatation if the younger people are not used to blind dilatation.
Yes, Dr. Keshav.
See, to use an Otis, you should have at least a 16 French urethra. Otherwise, you will not be able to put in this Otis. So that is the minimum criteria that people should know, that if you have to use an Otis, if it has to go inside, it should be at least a 16 French urethra. Less than that, you will not be able to use an Otis, because Otis is also a blind procedure itself.
and it is an additional investment. A good Otis urethrotomy costs you a lot. Yeah.
And otis should also always be done in a vertical position, vertical to the floor, so that it goes only till the bulbar urethra, not into the membranous or in the sphincter area.
So, what we conclude from this is either Otis or Clutton can be done selectively. It's not required in all cases. It is personal preference, how actually you are trained and how you are comfortable with. And for Otis minimum, we need around 16 French urethra to do a clean cut, and Clutton, whatever, both should be done up to the bulbar urethra and it should not be till the bladder neck. So we'll go to the next scenario. You have got a non-capacious urethra. Even after dilatation, it is not accommodating 22 sheet, and there is a large prostate there. So how you will deal with this situation? Dr. Girish? You have to unmute yourself.
This is a situation where we had to use a smaller sheath, no doubt. We cannot use a conventional sheath in this at any cost.
No,
So,
even now 22 sheet is also not accommodating, and the prostate is quite large. So what you will tell the patient?
no, the patient is already under anesthesia, and we discover this
Yes.
problem as we are
Yeah.
when we do cystoscopy.
Yes.
So what we do in such situation is, if possible, I will try to use Clutton's dilators and dilate the urethra and see if it accommodates at least a 22 French sheath. If that is not possible, the other option would be to do a perineal urethrostomy and do a TURP. Because once you do perineal urethrostomy, you will get access to the bulbar urethra, which usually is capacious and admits, and you can do TURP. And at the end of the surgery, you do the closure of urethrostomy and put a Foley's catheter, small size, maybe 18 French Foley's catheter, 3-way, and come out. That is a plan.
Lalit, sir, you want to add anything there?
One of the options can be to do the, if you are not able to accommodate even after dilatation, that means even after Otis, we are not able to accommodate. That is what the question is?
Yes, sir.
So in that case, one of the option would be to do, if we knew it before anesthesia, say for example, this situation, then we can do is a periodic catheter dilatation. We can put the catheter and change to next 2 French every day. So in 2 days, it will be good enough. That could be one thing if we decide we get it in the pre-operative situation. But if we are getting it in the operation table, then probably the perineal urethrostomy is the only option remaining with us.
Percutaneous suprapubic TURP is an option.
I don't think that percutaneous suprapubic TURP for a significant, for a little bit of bladder neck type cutting and that sort of thing, probably it may be fine, but otherwise it may not be a good one. We have done couple of bladder neck like that, but it was mostly just like a bladder neck and taking a one chip in the median lobe area, 1 or 2 chips there, that is fine. But doing a good amount of TURP or a reasonable TURP, I have no idea. I don't think so.
Dr. Girish, you want to add something there?
Yes, in that case, we totally change our plan. From TURP, you go for open prostatectomy because there's a large prostate, a small urethra, and if perineal urethrostomy is not possible, then switch over the plan entirely and do an open prostatectomy. But then you should speak to the patient anesthesia. I mean, patient's relatives.
Dr. Kamath, yes, sir.
Yeah, that is like in laparoscopy, you always take a consent that any time the procedure can be alternative. Dr. Lalit, with Dr. Lalit Shah's permission, I would always say that in every TURP, there is an alternative procedure can be done, because you always tell the patient that there will be no incision. You will be fine without incision. I am doing the procedure. And at the end, if the patient finds that you have a large incision, I mean, you are forced to do an open prostatectomy, or for whatever reason, maybe to control bleeding in the next scenario, probably you will come to a situation where you have to open and do it. So always there should be a consent for alternative route for remedy of the existing problem that we have.
But Kamath sir, how, in what, like generally we take consent for complications and problems which are happening at least 3% or more of your cases. But do you really think that this scenario qualifies for every patient being informed that you may be opened from above and you may need a simple TURP from above. Because patients have really low acceptance to any variation because they come preoccupied. TURP means no cut, no stitch. That's it.
If, for example, for a lower ureteric calculus, the standard consent form always says that you can even open up or do a PCN. That includes one of the inclusions in the standard PCN, even in the Western textbooks.
Sir, I am asking a very practical thing. Like in many things we write in consent and we don't talk about actually to the patient.
So, if you are talking practical, many of the times you can overcome this by a perennial ureteroscopy.
And we have got suggestion. Yeah, Chawla sir, please.
I think I'll echo what Aditya is telling. One, the 22 sheath is not going and the gland is large. So in this case, in ideal condition, I would have used little bigger sheath, say 26 French, because I can resect the gland quickly with the longer chips. Now here 22 French is not going and patient is under anesthesia. My take will be putting a catheter. If 22 French is not going, I'll keep 18 or 20, send him home next day and call him after 2 weeks. At that point, I'll be explaining him that I'll be going in, and if my sheath doesn't go in, then probably you will be a candidate for open prostatectomy. That also I'll assess it whether this gland is suitable for a section or a open. On open prostate, usually we think of 100, 120 plus and all that. That gives a little better enucleation and good results. So my take on this will be when patient is anesthesia, just keep the catheter, play safe, send him home, get him after 2 weeks. It leads to passive dilatation. Usually it's easy. We see 1 or 2 cases in a year happening like this, but in both the scenario, wherever you're seeing, we are able to go in. Maybe not 26, 24 or 22. That will be my take.
Chawla sir, my question in this is, in individual, if we exclude the institutions which can have, slender resectoscope, I don't think many urologists in individual capacity own a slender resectoscope because it is needed only twice a year.
Pardon?
I'm asking,
yeah. No, but
the slender resectoscope is not a common thing which many urologists own because it will be needed only twice a year.
Absolutely. But at the same time, you should again keep in mind doing TURP from perineal lithostomy, if you have not done, is not easy. You come out with the resectoscope from the wound quite often. Doing from anti-growth, I don't think there are many reports about that. So that's the situation.
What we conclude from this is, in case if the urethra is not capacious, probably passive dilatation from the catheter is a very good option. We can always explain the patient and we can do a passive dilatation. We can bring back the patient after 2 weeks. Perineal urethrostomy and doing a TURP is the option, but we need to take consent and we have to explain the patient. In case the gland is very large and the urethra is non-accommodating, open prostatectomy is also one of the indications for this. So we'll move to the next scenario, Dr. Aditya.
Yeah, so as we know, the urethra is the Achilles heel for the urologist. So we increase the difficulty level to next level. So now we have a stricture and first of all, how do we reduce chances of post-TURP stricture? That's why my question is to Dr. Keshav.
Reducing post-TURP stricture, you have to see that one is the instrumentation. That is the most important. You should use the right instrument. In case your instrument, the commonly used one is the 26 French Iglesias, which is used for a TUR. But if you are finding that it is not accommodating that, the other option would be, if you have a non-rotating scope in your theater, you can use the inner sheath and a suprapubic as told earlier. The next option would be that if you are institute or if you are having a slender resectoscope of 22, you can use 22 resectoscopes, which will accommodate easily, but you cannot resect very large glands in that because it takes a lot of time to do it. So you should, and adequate lubrication in between. Also, you should see that the lubrication is good. Your meatus, when you have gone inside, you should have adequate meatus. When your instrument is going, you should see that the time taken to resect is also important. If you are resecting for a very long time, the chances of strictures are more. So these are the ways that you can avoid strictures in post-TUR.
Yeah, Dr. Kamath sir, anything you want to add?
Yes, I fully agree with Keshav. I have no other additional inputs to say, but I would always insist that you use a smaller instrument with a suprapubic catheter. The chance of stricture will always and the indwelling time. They say that with the to and fro movement of the receptoscopy gives what is called when you use in a tight urethra, cheese grating effect. You know, the receptoscope moves and it injures the urethra without your perception. So a freely moving instrument, if it does not move freely, that is the patient who is likely to develop stricture. And sometimes use good quality jelly. If you use good quality jelly, I had seen strictures when the quality of the catheter was low and quality of the jelly also was low. This may add to a small percentage, but finally it is the instrument size, the indwelling time.
I would like to add one scenario to it. Actually, one of my friends shared his experience. He had back-to-back 5 to 7 TURP patients developing strictures. And the possible reason he was using a Chinese sheath, which may be having leaking current. So what would be the way of, confirming whether current is leaking or not? I mean, apparently everything looked fine. The surgery went well. Dr. Chawla sir, if you can add something.
No experience with this type of a problem. But what Dr. Kamath was adding in that, I have seen few urologists advocating coming out with the whole assembly out and instilling the jelly, at least procedure of 60 to 80 minutes. So meaning thereby that when they are doing TURP, they will come out, they will put the jelly again at least once during the whole procedure, depending upon the size of the gland.
Yeah, I agree with Dr. Chawla, and this I do very often. Because the ischemia is also very important. If the sheath is gripping the urethra and you know that it is gripping, then it is ischemia which is occurring. So you come out completely, wait a minute and put jelly and then go in again. It makes the life much easier.
So what, yeah, Dr. Shah sir, you're saying something?
No, I'm not saying something.
Dr. Girish.
Nothing to add. Already.
Yeah, Girish
spoken.
sir, yeah.
Yeah, I would also like to add the cautery settings are also of probably some importance because we are not given importance. Keep the minimum cutting as well as a coagulation current because that is a scenario that you are alluding, Aditya, when you spoke about your friend having 6 to 7 strictures, probably leakage. And another indication is when sometimes when you're doing TURP, if the cautery settings are very high, or hands, the fingers become warm. You can feel that the cautery sheath has become warm. Probably there is another indication that there is a leakage of heat, if not current. So keep the cautery settings low, as low as possible.
So to conclude on this point, I'll just summarize: use of smaller sheath if possible, shorter duration of the procedure. If the urethra is gripping, better take out, let urethra breathe and go in again. And they may be the methods, and of course, good quality instruments reduce chances of current leakage and ultimately developing of stricture. Next.
Aditya,
Sir.
the mistake of trying to do very big glands with by transurethral resection monopora, because you will be able to complete the procedure, but you will not know the indwelling time is more. So size of the gland is
Right.
So this question is for Dr. Anurag, Dr. Yadav.
Yes.
Many a times we find that there is a big prostate and incidentally we find a small stricture also in that patient. So what is your approach to this sort of cases?
Yeah.
You will combine your TURP or you will just do a VIU and come back again? Prostate is quite large, it's around 75 grams.
Yeah. The thing is, if you believe that he is obstructed due to prostate also, that means the stricture has been there for quite long. It is an inflammatory stricture, no recent catheterization, which must have been there for quite long. And the symptoms have occurred now due to enlargement of prostate in the last few years due to aging. Then I believe that both should be dealt with together in the same sitting. If the stricture is found to be very, very narrow, then I may do only OIU and leave the prostate and explain to the patient. And at times we have patients in whom we know that both things are present by a previous RGU. We know, then we tell the patient that we may do only OIU and not the prostate, and you may need it later on. So all three scenarios are there in which you can do both. You can do only OIU, or you can do, prostate and OIU both. So if I believe that it is the enlargement of prostate in recent years which has worsened his symptoms, I would do both in the same setting. And I don't believe that bulbar strictures will cause incontinence if I do them simultaneously or metachronously. I don't believe they will cause incontinence because strictures
Lalit,
are in the bulb only.
Lalit sir, you want to add anything there?
Yeah. See, what most of the time in such scenario I do is, you can get, just by seeing this type of the stricture, you can get a rough assessment whether this was the cause of the problem. You have to do the urethrotomy and go in, and then we do what is supposed to be called as the Wardle test, fill up the suprapubic, fill up the bladder, and just take a rough assessment about this. Okay, how much is the flow? If the obstruction has been appearing to be released and a very, very good flow is there, I would not do TURP. Otherwise, I will proceed with the TURP. Though it is said that this particular test does not correlate very well with the post-operative flow rates. But in practice, we have found it very useful. And even for completing whether our TURP is adequately completed or not, we are following this practice only.
Since it is a very important scenario, I will ask Keshav sir, also we'll ask a few more panelists. Dr. Keshav, you want to add anything there? Because
no, if it is a short segment stricture, see, for the stricture to be symptomatic, it should be less than 11 French size. Only then the patient will be symptomatic. If it's more than 15 French, the patient will not have obstructive voiding. If you are having a patient having obstructive voiding symptom and you find the stricture to be accommodating your cystoscope as 17 French, it's unlikely that that stricture is the cause. So the prostate will have to build. If it's a small stricture where you can, and a soft stricture, you can do simultaneously VIU and do the prostate. But if you find on endoscopy that the stricture is very narrow and you find the spongiofibrosis to be more, then I would just handle the stricture at that point of time, leave the prostate for the next time.
Yes, Dr. Girish, you want to add something there?
Yes. As you said, it's a very important thing and we find it very common. We should remember that when we decide, in this patient, when the urologist has decided to do TURP, he has decided it based on the size of the prostate, a digital rectal examination, and this stricture is just an incidental finding during surgery. So most of the time, this patient merits VIU along with TURP. What I mean to say is, it is never sufficient to just do VIU and say that this patient doesn't know TURP, because it has been decided before that the gland is enlarged. That's why we end up doing VIU and TURP.
Enlarged gland, many times you can just give them alpha blocker post-op and we can reassess the patient after some time, because probably this was a static block there, which was because of that the alpha blocker is not acting before.
Yes, it could be done. It could be done that way, but we have to be practical. We have given anesthesia, there is a stricture, and you say it's a small stricture, not a very large one, not a very bad one. If it is a bad one, because your case scenario doesn't talk of a bad stricture, you're talking about small stricture.
Small stricture.
So, yes, in which case, stricture is not the cause of the problem. It could have compounded the problem, but it is a prostate. So
Arun,
it makes no sense to do VIU and tell the patient, well, you alpha blockers. So it is better to do
again.
Girish sir, how does one differentiate or separate stricture has happened because of TURP or not? Because many times we do TURP afterwards and patient will develop a restricture in some time and they conclude that, okay, this may be the reason after TURP they have developed.
No, but here, once we find a stricture, we have to record it in our OT notes, and we have to, if possible, record it by video also and tell the patient that there is a stricture, we have treated the stricture, but at the same time, since the prostate is enlarged, instead of giving alpha blocker, I have done TURP, and stricture has to be dealt with on its own merits in the post-operative period.
Arun sir, you wanted to add something there?
Yeah. So what Dr. Keshav has told, a short stricture, a focus stricture with superficial, which is superficial. That means it can be divided at least with at least a nice one cut, and it gives away. And two, this stricture should be in the mid and the proximal bulb, which are easy, which can make you continue with the TRP. So site will be important. I'll take only strictures which are mid bulb to proximal bulb and very short, less than 5 mm, and superficial. With one cut, it gives away just like anything. That will be the indications for me to continue the TRP. In any scenario which are beyond that, stricture located in other situations where I need a multiple cuts to get to make the caliber good, I'll just divide the stricture, put a catheter, and come back later.
So, yes, Kamath sir.
I would go back to history and see. Generally, these patients are in the prosthetic age group. So we preoperatively we will not be suspecting any stricture in this patient. But if you have taken a careful history, if the history of avoiding obstructive LUTS is of a very long duration, say 10 years, 20 years, like that. And number two, if there is any recent catheterization or patient had any insult on the urethra in the recent time, and then the LUTS became more obvious, I would think that the problems are because of the stricture and not because of the prostate. So history is a very important thing that will make you decide whether it is all the problems are because of the. So a recent insult on the urethra, either a catheterization because the patient was unconscious or something like that, head injury, or patient needed catheterization for different reasons other than obstructive LUTS, and then the symptoms develop, then I would stress more on the stricture. And if the patient was absolutely all right before the urethral insult, I would do just a stricture treatment and then come out.
So to conclude, what I feel is history is very important. We should look back the history of any instrumentation and long duration to assess whether it is purely because of prostate or because of stricture which was there before. In case we do a cystoscopy and the stricture is very soft, supple, and we can just manage it by 1 or 2 cut, and it is in the bulbar or mid bulbar region, we can go ahead and do TURP. In case the stricture is very dense and it is long, then probably it's better to just put a catheter, start the patient on alpha blocker and reassess him. On table Wardell test can be done to assess the flow as well, whether the prostate is really the cause of obstruction or not. So we'll go to the next scenario.
Yeah. So now is a scenario where we already know there is a stricture and there is a big prostate. And I think the first thing will be to first decide whether which problem is causing more symptoms, because stricture is for sure, and what would be our combination of treatment. So in the given scenarios. So I asked this question to Girish sir.
Here, if I had to go by the RGU that you have shown, okay, then I would treat the stricture and I would not give importance to prostate as far as TURP concerned. So I'll treat his stricture and then give him a medical management and see what happens. Only if there is a problem with voiding, only then I will consider TURP. But here I would treat stricture either by VIU or by urethroplasty. I mean, I can't see it very, very well, but probably it appears to be a long segment stricture here, the RGU that you have shown. So I would do a urethroplasty, reassess him later if needs TURP or not.
Dr. Chawla sir, you have same.
Again, the point here is the size of the gland is not the indication to choose TURP. So that is important. You may have a patient with 100-gram gland with a normal flow. Again, what Girish has told, it is a stricture. If you can see here, the stricture demographics is the distal urethra dilated up to a point of narrowing. And I think to me, if you have given me an MCU, I would have known the extent of the stricture. So depending upon the length of the stricture, I would have decided whether I am doing at least one VIU and seeing the response, or a urethroplasty if my VIU fails. I will not bother about the size of gland in altering my management first. Here the stricture management will be more important, or will be having more priority.
I would like to add one thing. If we know preoperatively that there is a stricture, then I would like to do an MCU. MCU will tell us the status of bladder neck. If the bladder neck is funneling well and the posterior urethra is also dilated to some extent, even with an enlarged prostate, the posterior urethra will be dilated in such a bad stricture. So we know that the point of obstruction is in the level of stricture and not the prostate. So only stricture will be dealt with, not the prostate.
Okay. So we conclude that if the stricture and yes, sir, Kamath, sir. Yes.
Apart from all the strategies that we are going to adopt, I would insist that we do a very good pre-operative counseling on this patient. That is, this procedure is not going to be straightforward. We'll go in and see, and it could be one stage, two stage. So good pre-operative counseling is very important in this patient. You spend some time with the patient.
So to conclude on this point, stricture with the TUR with large prostate is definitely a diagnostic dilemma and a challenge treatment-wise. Stricture gets the first priority of treatment, and with due counseling and consent, further management of prostate can be done after stricture is cured. So next, yeah.
So now we come to the next scenario. We have this for Lalit, sir. No, we have done a blind dilatation by Clayton's, and by chance we have made a large false spaces there. So whether we'll continue doing TURP in this case, or what will be your choice?
What is the location of the blind passage? False passage?
It's in the bulbar urethra. Suppose it
I will
is
continue. We can continue.
There's a large blind.
I don't think that it makes a great difference. What you would do is that with the visual obturator or with the cystoscope and all that, we would just pass a guide wire so that we know there, and then we can proceed inside and do the things. And in the same time, whenever you are putting in the catheter, after the procedure is finished, TURP is finished, we have to thread it over the guide wire, not the usual blind catheterization. I don't think it will make a great difference.
Anyone is differing with this point, or everyone agrees?
No, you should see that if your false passage has not done any damage, in the sense there's no extravasation, nothing happening, no hematoma, nothing, then you can probably, what Lalit Shah says, you can, with the guide wire, you can go inside, finish, and then introduce the catheter with the guide wire. Leave the catheter for a longer time than what you usually do for the urethra to bleed.
Okay.
Yeah.
Now we have come to the next condition.
Nitesh?
Yes, sir.
So bringing here what Dr. Keshav has said. So Dr. Lalit said that he will go ahead. Again, the point is correct. Now, when you are going in, you have to make sure that you are finishing the procedure, and you are not coming out and going in again, because that is again lead to exhaustion. But I'll just quote one patient where, with the similar situation, we have gone in and we have seen a foreigner gangrene in the postoperative period. Again, indicating that if you have infected urine or infected fluid going in and exhausted, this is one of the scenario which we have faced.
Yes, Dr. Girish.
Yes, there are two things I would like to speak here. Now, when you have created when the urologist has created a false passage, it is likely that there was a stricture which has tried to dilate and created a false passage. Because it's very, I mean, practically that's what happens. Very
many times blind dilatation with Clutton's and all, suppose junior resident is doing, he may create a false passage in those scenarios.
You're talking about
there's no stricture, you have done a scopy and you have done a blind dilatation.
Yeah, we've done blind dilatation, normal urethra, but we have damaged the urethra. So in that case, most of the time, I think Dr. Lalit Shah is right that we can just go ahead and do a TURP. But at the same time, if it is a very bad blind passage, false passage, and if I cannot put my TURP sheath without damaging the mucosa in the right passage, then I put a catheter and come out. But that's a rare situation. But if it is very difficult, I think it's better to abandon it.
Yeah, again, one more point here I'd like to add is, in the situation where we have seen this type of complication, I have seen what Nitesh is quoting, that some junior agent. Two scenarios I have seen where whole the mucosa on the pandus urethra has got avulsed. and we have to use a uteroscope, put a guide wire. Again, in this type of scenario, it's better to keep a guide wire and keep it into the bladder, so that whenever you're coming out, you have a safe passage along the guide wire, along the floor, you can go in and come out.
Yes, Kamath, sir.
One trick regarding putting the guide wire, so many times the flap of mucosa is so much abutting on the rest of the urethra that every time you try to enter, it always goes into the pons passage. So one of the tricks at this time to put a guide wire itself is to stop your inflow, push the bladder from the suprapubic area, and then the actual real flap opens up, and it is at that time that you push the guide wire in.
So we come to the next scenario. There is a false passage, but this time it is because of the balloon inflation in the urethra. Patient have come to you for TURP referred by one of the GP, and one of your he was in retention. One of your subordinate have inflated the balloon into the urethra. So what you will do in these cases? You can see here the balloon was inflated into the urethra, and there is a large false passage. You are able to enter, but still it is little difficult. So whether you will proceed in this case, and what is the medical legal implication in this? Lalisa, sir.
In that scenario, seeing this, the picture that we are seeing, I would just simply put in the catheter, leave it for about a week or 10 days, and then we'll take him back again.
And is there any medical implication of this, medical legal implication in this, we have damaged the urethra?
No, see, we are going to record it, it is there. No? So there is not going to be any medical legal implication for us. Even if there is an implication, it will be for the person who has created this one.
Shah, sir, how long one is supposed to maintain these recordings?
Huh?
So patient have come to you with retention referred by a GP, and your subordinate have inserted the catheter.
Okay.
So the onus is on you only.
so see what in that case there is nothing like that, because if you put in the catheter, because it was only a injury like this, it will heal and it will become all right. After 4 or 5 days we can go ahead and do the TURP, and later on we will have to watch for the formation of the stricture.
Dr. Shah, sir, how long one is supposed to maintain the recordings of his problematic cases? What is the timeline?
Sir, medico legally there is no requirement of keeping the recording, endoscopic recording, as on now. Till date, any case is not there where they insist, and so you can always say that we do not do the endoscopic recording.
And Keshav, sir, what are the tips to find the true lumen once you have raised a flap? So what are the different tips? One tip already Dr. Kamath have explained.
Try to use a smaller caliber endoscope so that you will be able to go through that. That's one of the thing, and you have to have a good irrigation for you to see that region, and see whether you can pass a guide wire and go through that.
Anyone wants to add anything there?
Number two, not to give rapid irrigation. You just slow down the irrigation, and you find that in a particular small direction the irrigation is going. You follow the path of the irrigation. There will be some amount of bleeding, and once you do small irrigation, you find that the irrigation flows towards the right passage, not at the pons passage, and that's the way to go.
Some suprapubic pressure can guide.
Yeah, already Kamath sir have already said that. I think sometimes following the mucosa also helps in this sort of cases. We can just see the mucosal vasculature and we can follow that. Dr. Yadav.
Yeah. Sometimes you see two openings, not really a false passage, but an old false passage by repeated dilatations or something. So you find two openings and you're not sure which one is. So rule of thumb is in the bulbar urethra, the floor one is a false passage, and something which is above is the real urethra. The second thing is, if you can't see anything even with a smaller scope, and sometimes what happens is you don't see any opening in which you probe your guide wires. So you put methylene blue in the bladder and give pressure, and then it will come. You'll know the real opening. Then you put a guide wire.
Generally, the wider one is the false passage in the one which.
So with this, we conclude this. we can, in case there is, and we have made a false passage and it's not very large and there's no much of extravasation, we can proceed with TURP, but we should avoid coming back, and we should always place a catheter on a wire. In case the false passage is very large, it's better to stage the procedure, and after 2 weeks we can bring the patient again and do. For finding true lumen, it's ideal to use a smaller scope. We can always give some suprapubic pressure so that the flap comes down and the urine can be seen coming out. We can also use methylene blue inside the bladder, and we can see methylene blue coming out. And most of the time, uh, the uh, the true passage is usually above, and we can always follow the mucosal lining as well. So we'll go to the next scenario.
So as it is, although this scenario is not very common with Indian patients, but in our international patients, we do get stuck with a situation with large pelvis and the sheath is falling short. So what should be done in that scenario, Dr. Girish?
I have faced this situation in TURP, but as well as in TURBT. I think what I did in such situation is did a perineal ureterostomy and completed the procedure.
So what can you give some small description how one should do a perineal ureterostomy, and when do you close it?
Yes, yes. I presume, see, there are two things here. One is a large phallus and second is erection during after spinal. I think
we are talking about large phallus. We have taken care of erection.
Yes, yes. We'll not discuss that part. Yes. So you just clean the perineum and put a catheter, locate the urethra, make a perineal incision the way you do a perineal incision for urethroplasty, and take catgut or vicryl stay sutures on both sides of the urethra, make a cut. Make an adequate cut. Don't make a too small a cut, because what happens is closing a good cut is easy, but traumatizing a small cut while doing TURP can jeopardize urethra. And then you pass in a TURP sheath and complete the TURP. Only problem is stability. There is no leverage, because the moment you go in, you'll find the prostate. So you keep on coming out. It's not as easy as you do when you go through the exourethral meatus. At the end of it, you close the urethra, put a catheter, and maybe about 7 to 10 days, you'll keep the catheter and come. Whether you'll be able to put a 22 French or not is depends on the size of the urethra. Maybe you can put a 20 or 18 French 3-way Foley's catheter.
So, sir, this ureterostomy, in your opinion, it doesn't really pose any risk of urethral stricture developing in that area later?
I don't know, because frankly, I have not followed these patients. But I think probably we make a bigger cut that is safer than making a very small cut and trying to push the instrument in. Maybe that reduces the stricture rate. But I don't know what happens in the long term. I really don't know.
Dr. Kamath, sir.
Yeah, in the classical text, when the previously they used to do a urethrotomy for other reasons, say removing a urethral calculus or something like that. Perineal ureterostomy, they say it does not cause stenosis. That is one point. And the instrument that this is a problem. The stability of the. I was just wondering the idea whether you can use a smaller amplux to have stability for your instrument. And we have not used it, but I think that is one idea that mean that perineal ureterostomy. And other way of doing perineal ureterostomy is to pass a bougie, and you turn the bougie 180 degrees, a clutter's bougie, and then turn it 180 degrees. Instead of pointing towards the patient, it points towards the perineum and cut on the bougie, so that you can do a perineal. And the rest of the steps are same.
So, Keshav sir, as
Aditya,
yes,
if you have international patients, you should start keeping extra long resectoscope.
Yes. Like the slender one. I think slender resectoscope and long resectoscope are a rarity.
Yeah.
Aditya, could I?
One point Aditya, I'll make here.
Yes, sir.
Sometimes you think that this problem you are encountering because of the length, but at the same time, we have seen under anesthesia, it just rolls over the sectoscope. Sometimes you can continue. The length may not impede in your section, It's just the relaxation is so good with the placid organ that you can continue even if your loop just reaches or the tip reaches up to the bladder neck. That scenario also we have seen.
Yes, definitely, sir. So anyone else has to
See,
add
bulbar urethra will never in here because we are not going to do the urethrotomy, bulbar urethrotomy because of the stricture. It is because of our receptoscope falling short. So this bulbar urethra per se is also very capacious. So it never forms a stricture. I have done in 3 cases till now like this, and they never had any problem.
And I think the indication of transocecal adenomectomy or resection, I think evidence in itself is not very much. And with the image itself would suggest here, if the pendulous abdomen is there, this technique really becomes useless. I mean, with the overhanging abdomen, it will not allow movement of resectoscope. So I'm really not sure if anyone can add to anything to this technique of percutaneous TURP. That can really be an option?
Not much of literature is available about this because there are other alternate ways where you can handle. So that is the reason why people would not be doing too much of transocycle TUR, because you have alternate ways of treating these patients than doing a transocycle TUR.
Right. Next, Dr.
So coming to the next problem, Dr. Yadav, you are doing a TURP and halfway through you find there is an erection there. So whether you will continue or what you are going to do in that case?
What about halfway? In the beginning also, you wait and you find the full erection is there. You can't even lower down the phallus. You can't enter. There's a lot of difficulty. And I have used injection of phentolamine or mephenterine, which is available with the anesthetist for BP. So they give me a little bit of mephenterine in the syringe. I dilute it and just inject it into through the glands into the cavernosa, and it most of the time works. And of course, we can aspirate just like in priapism and leave a scalpel set and dripping. The blood keeps dripping and it usually responds. I don't remember I have to ever abandon a procedure because of erection.
Dr. Kamath, you want to add anything there? You are doing a TURP.
If it is intractable, sometimes converting to GA from spinal anesthesia will help.
The anesthetist nebulization also works, I think.
Yeah,
I think they
just
keep
getting add, yeah.
Injection of NORAD always works, which has never seen that it doesn't work. A diluted NORAD injection always works.
Arun,
So there never have been an instance where you have to abandon the procedure because you have not been able to bring it down.
Arun sir,
Maybe
yes.
we are lucky so far.
Yes, sir. Arun sir, you wanted to add something?
Yeah, means like what our anesthetists have done is when we tackle this issue, I think the glycopyrrolate they have used, and what I can recall is yes, there are few who have used ketamine also and asked us to wait till the ketamine effect is over, the stage of tonic is over, and then probably we get the erection which is manageable, and we proceed with this. I have not encountered any situation where we have to put a needle or inject anything and or abandon the procedure.
Keshav sir, you wanted to add
Yeah,
something?
I have had an opportunity that I have at the start, my anesthetist tried doing everything. GA, it did not come down. I tried ephedrine, diluted ephedrine, it did not work. Irrigation did not work with saline. I have abandoned the procedure and taken him 48 hours later on with GA. We did not try giving spinal because after spinal, this fellow had very bad priapism.
Just like inability to have erection, having an ability to have erection in any situation can be counterproductive.
Probably you send the sister also out. Okay. So the next question is, suppose you are not able
Girish
to.
sir wanted to say something. I think this
I
was
think
sent
just
by.
a little more
Okay.
aspects about it.
We'll ask this. The next question is for Girish sir, because the image was provided by him, beautiful image. Suppose we are finding it difficult to bend the scope down. There is a tight suspensory ligament there. So what you will do in this case?
That's what I found it, as is my photograph, I found it extremely difficult to do the surgery. It's people who are muscular, obese, short, and the suspense ligament is so tight that you find, and especially those with a large median lobe. These are a nightmare situation. Somehow the problem occurs, you can go to the prosthetic fossa, but because you cannot bend the scope any further down, you cannot enter the bladder. You try to wriggle and you keep on damaging the median lobe or the neck of the prostate, because the 6 o'clock part of your sheath is going to abrade over the prostate and the median lobe. But somehow you turn it clockwise, counterclockwise, bend it a little more and try to somehow negotiate into the urethra. Once you, in the bladder. Once you negotiate into the bladder, you flatten the bladder neck without coming out. Once you take a few chips of the median lobe or the bladder neck, then things become a little more simple. Then all you have to do is ensure that you don't come out and finish the bladder neck first, then things become simple. That's what I have done.
Any panelists want to add anything? Anyone have given incision or have cut the suspensory ligament in such cases?
I have to do it in one case so far. I had done that because I tried all the best and all that could not succeed. Very obese and all that. And then ultimately I had to do in one case so far.
Okay. Any other experience from any of the panelists here? So we'll go to the next scenario. So to conclude, I'll conclude it. So in case we find erection, we don't have to abandon the procedure. We probably can, if the patient is under general anesthesia, we can deepen the anesthesia. In case spinal itself can be a cause of priapism or erection, and we can give intracorporeal phenylephrine or ephedrine there. And probably we have to, the genitalia should be minimally handled. It should come out with all this measure most of the time. In case patient is having very tight suspensory ligament, then probably we have to try to negotiate the scope and try to do the procedure as fast as possible. And at times, probably we may have to cut the suspensory ligament, but for that a prior consent is must. So we go to the next scenario. Yes, Aditya.
Yeah. So, Dr. Keshav sir, in case of stiff bladder neck, and we are really not, like Girish sir already mentioned, that try to get over the bladder neck and flatten it, but we are not just able to go through it. So what could be the causes of it, and how one should try to deal with it?
There's something like sometimes it's called the frozen prostate. You will not be able, that it will not yield, and it's very difficult to go through. So you can put in a guide wire and go along the guide wire and see that you will be able to enter it. But sometimes it's very difficult. Maybe you will have to use smaller scope if you are using a 26 French. If you are not able to, if you have a 22 French resector scope, you should be able to see. But you will have to put in a guide wire to see whether you can follow that guide wire and go inside.
Sir, many times even the scope starts bending and mooning is seen, like I've seen in a couple of cases.
We can see here also the mooning can be seen on the scope.
Yeah, on the scope, there's a lot of pressure is coming. How is retrograde resection an option here? So we cannot see the other side where we end our resection.
The retrograde, I have no experience of doing a retrograde resection at all, so I cannot comment on.
Yeah, Dr. Yadav.
I think one of the reasons may be your high lithotomy. You try to ease out your lithotomy, or try some other position on the table, and you may be able to enter. And one patient I remember in which I was not able to enter at any cost, and I did a kind of incision with a cystoscope and a Bugbee electrode. Cystoscope even was not able to enter. Cystoscope is a little easier to enter because of the beveled shape. So cystoscope was even not going, 19 Fed cystoscope. I used cystoscope a little at a distance from the bladder neck, and I used a Bugby electrode, which is available, and incise the bladder neck.
You are able to see bladder across.
You can't enter in this. In this video, you can't enter, but cystoscope usually enters because of the beveled shape. So Bugby I have used.
You retrostomy and doing BNI is an option in this. Probably will cut down the course of.
I did that BNI kind of thing, and you can also evaporate a little bit of prostate. Remember, Storrs was making vapor throat kind of thing and different shapes. So I use Bugby electrode to evaporate also a little bit of prostate in this scenario. And in a regular TURP also, the ball electrode that I use for fulguration in the end, I use a cutting current and ball electrode to smoothen out or flatten the little bit bumps on the fossa. So Bugby electrode or ball electrode can be used to evaporate also prostatic tissue.
Dr. Kamath sir,
Yeah.
Doing dilatation over guide wire in this situation, will it help over the guide wire if we have,
You said even the guide wire is not going inside.
No, guide wire will go. The bladder neck, just we are not able to enter through the scope. So if we gradually dilate, should it help? Any experience in such situation?
No, I have no experience, but concept-wise, acute dilatation that way may not help. If you can get it.
Can I add something?
Dr. Anurag has got a lot of good tips. I think that is the when you are using when your resources are limited to the extent of monopolar TURP. I think that is the way out. One other way out is to do a suprapubic cystostomy, and then from that side you can try to do something to the bladder neck, and then again go from for your.
Yeah, Girish sir.
Aditya, if you are not able to go into the bladder, but you are almost there and you are able to see the bladder, then probably you can think of doing a retrograde couple of cuts. But then that is that when you are almost there at the bladder neck and you are able to see the bladder inside.
Just not. Yeah, we should know the other boundary.
It cannot be a blind thing. You are not able to see the bladder also, and then you are trying to do that.
Yeah, Girish sir.
Yeah, I have faced this situation, and I'll tell you what I did in that situation. See, normally when we do TURP, we enter into the bladder, we inspect, come out almost to the veru and start resecting. Here it is not possible. You have gone almost up to the veru, you see a mountain in front of you or something very narrow, and you just can't go beyond that. So what I did in that situation is I kept the sheath there. I just protruded the loop and took a blind cut at the bladder neck. There is a blind cut. But you have to be blind. I mean, you should not be so blind that you make a perforation. So you take multiple such cuts, 2 or 3. After that, things become very simple. There is no problem after that. But the first few cuts have to be at only the loop protrudes, and they're blind cuts at the bladder neck at 6 o'clock position.
So what you are suggesting, till the part you see, you advance your loop and try to resect that part, then advance and then again do the same thing.
Yes.
Can I add
Chawla sir?
First few cuts are blind, but they're not totally reckless. They have to be careful, but it can be done.
Arun sir.
Yeah. So the different options which I have used in the situation like this with a recalcitrant bladder neck, using a VIU sheath and VIU blade and giving a cold cuts at 5 or 7 o'clock. Okay. Number 2, the same. I'll take my resectoscope, but I'll change the loop to my Collin knife. So what I'll do is eventually where the tissue is abundant, where bladder neck support is more, I'll use the Collin knife. Even if a loop goes in, it will be retrograde cut. Otherwise, it will be reverse cut. Just to open the bladder neck. Once I am through, my tip of the scope goes, then rest of the procedure remain more or less the same. I'll change to loop and carry on with the procedure. So meaning thereby to conclude, I have used cold knife in making this bladder neck open. I have used Collin knife, both as an antegrade and retrograde cut to open it and then converting back to the similar procedure.
So to conclude, in case of a stiff bladder neck, if we are not able to enter, the options may be in the form of resecting part of the gland, trying to get some gland in one cut and then proceed, and giving incision with cold knife or cold cut or Collins knife is option. And in some cases like with burning with bug bee electrode or vaporization of prostate can also be an option. Next.
So now coming to DNI. So Arun sir, what is your preference in young patient, unilateral versus bilateral? What do you prefer and why? Chawla sir, yes sir.
Unmute sir, please unmute yourself.
So I'll prefer two incision at 5 o'clock and 7 o'clock. I'll see the ventral floor in between the two incisions, between 5 and 7, how much is the tissue, and that I resect it or not will depend upon the operative finding. My preference will be having two cuts, 5 and 7 o'clock.
Even in young patient? Chawla sir, even in young patient also you will prefer two cuts?
Yes, yes. Young means you are talking about a patient who
is having a bladder neck obstruction, completed family.
No, this is we have to wait why we are giving bladder neck incision in a young patient. Whether it is a primary bladder neck obstruction in a young patient, or it is a part of chronic prostatitis where you are seeing a non-compliant urethra with a short prostatic urethra with a high raised bladder neck. That is a different scenario. You can have a unilateral cut at 6 o'clock. But otherwise, keeping in with the typical scenario, it will be bilateral incision at 5 and 7.
So, and what about the intervening bridge? Whether you cut it or you just leave it there?
Yeah, that's what. It will all depend upon how much tissue I have. That will be on when we are doing the procedure. I may use what you can say a rectal finger to see how much tissue is there between my resectoscope sheath and the rectal finger. Depending upon that tissue, I'll decide whether I resect it or not. And because when you are giving incision and you are deepening it, you will know how much tissue is bulging out. Whenever you come close to the capsule, when you are giving incision, you will know the tissue, the benign tissue, the adenomatous tissue is bulging towards you. That will give you an assessment whether I do section for the tissue on the floor or leave it.
I think
Dr. Nitesh, we have to go a little fast, I guess. You're already 2 hours into it.
Dr. Kamath, yes.
Most of the times when you give cut at 5 and 7 o'clock position, you will find that the tissue is always with us. So I always resect it in between tissue. You will find that it is the tissue is more than what you had imagined before giving it.
So what we conclude from this is, in young patient, probably it is preferable to give a unilateral cut at 6 o'clock position. In elderly patient, probably we can give 5 and 7 o'clock position, and we should reassess the intervening tissue. If it is quite large, significant, better to remove it. So we'll go to the next scenario. Yeah, Aditya.
So what, Dr. Shah sir, what should be your approach in case you find a large bladder stone along with questionable prostate? You're not sure whether, the prostate is there, but how does one go about?
Then I will deal with the bladder stone, put him on the alpha blocker, and then see how he behaves. And with the counseling that he may require the prostatic management later on, surgical. At this stage, I would not necessarily do the prostatic surgery.
So large bladder stones generally don't happen without reason. Generally, there is a lower tract obstruction, some reason why the bladder stone remained there and grew so long, big.
Yeah, that point is also very valid, but still, I would like to do it in 2 different stages.
You would like to. So anyone would want to take it in one go, remove the stone and do that prostate?
Yes, unless it is a proven ureteric stone in transit, ureteric stone which was documented and it has come in the bladder and stayed there for some time. Unless it is a ureteric stone in transit, a primary bladder stone which is formed in the bladder needs some obstruction in the outflow tract, and I would do both cystolithotripsy as well as TURP in the same sitting.
Yeah, Girish sir.
uh, it is decided by the surgeon intraoperatively, depending on the size of the stone as well as the size of the prostate and his capability, whether he can, how fast he can finish, and his own estimate of the hardness of the stone. So there are two broad possibilities here, because it says large bladder stone with the big prostate. That's what the slide says. So either you do cystolithography and do TURP at the same time. But if your judgment says that you cannot do, then other option would be do a suprapubic cystolithography, keep a suprapubic catheter, and do the TURP. These are the two broad options which majority of the times we'll be able to deal with this situation by these two options.
So to conclude, the tackling of a stone becomes the yes, sir, Chawla sir. Yes, sir. Actually, your screen is tilted. I could not see your hand. Can you just, yes, sir.
Aditya, just combining PCCL or what you say suprapubic cystolithography with the TURP. I think when we do percutaneous cystolithography, we usually use a amplas which is 26, 28, or 30 because we want to just blast the stone and a larger chunk of fragments can be taken out quickly. But the issue is when you are doing TURP, this extraction from that suprapubic opening becomes an issue during the time of TURP and after the procedure, unless until you combine it with an SPC postoperatively and retrograde Foley's, which is of larger caliber of three-way.
So, will there be any, Dr. Nitesh, next slide if you can put. So, will there be any change of strategy if the there are multiple stones with prostate, not the single large stone? Will the treatment option should differ? Keshav sir?
No, you can, if you are multiple large stones, if you are able to finish with cystolithopaxy or cystolithotripsy, you can combine both prostate and the stone together. I don't think if they are smaller stones, even if they are multiple, you will be able to do cystolithopaxy and do the TUR at the same time.
So if there is a big median lobe obstructing these, so only the partial dissection, or still we should go for the complete TURP?
I think you should do a complete TURP because only the median lobe would not be sufficient, because he will come back again for a re-TUR later on. But if this, it all depends on how many stones are there, how long you are going to take to finish that. If the surgery is going to be very prolonged, you are doing something called as palliative resection for that period of time, so that he'll be able to void post-operatively. But that would not be the ideal TUR for him.
But sir, with multiple stones and using Mormere punch in such a case, we generally end up with very bloody field by the time you because the sharp edges of broken stone, they cause a lot of bleeding in the bladder. So will that be a concern?
No, if your vision is not good, if your vision after you have finished the stone, if your vision is not good, don't try to do anything. Put a catheter and can always come back and do the surgery later on. If your vision is good, if you have handled the stone very well, you can combine both these procedures together.
Okay, so to conclude, the larger stone, if the bigger stone is there, one can decide to deal with the stone first and come back and deal with the prostate as the time permits. The options can be, for stone can be PCCLT, suprapubic cystolithotomy removal, or even endoscopic with punch in case of multiple stones. And in the end of a stone procedure, the vision will decide how does one go about the prostate. And yes, both can be combined. Yeah, next slide, Dr. Nitesh.
So coming to the next scenario, where we have bladder mass in along with prostate. So Chawla sir, we have got three different videos. So there is one small polypoidal mass in one video. In second video, there is a small mass along with a bladder neck mass. That again is very small. And in third video, we have got sessile mass. In which case you will do TURP with TURBT, or you will just stage in all three cases?
Yeah. So I'll take one by one. Small polypoidal mass means that with one or two section, I can finish the mass and take this completely out, where I can follow with the TURP. A small mass with bladder neck will be first dealt with the resection of the mass and given it separately for the pathology and continue with the TURP. But a sessile mass where the treatment may altogether change depending upon the histopathology I'll be a little skeptical about this. So any large mass which is more than 2.5 or 3 centimeter, any mass which needs a long time for resection, any mass where I have a doubt that histopathology will change the treatment from endoscopic to a different management, say it comes a muscle visit, I'll stage the procedure.
And what about the mass which is there near the prostate? In the second video, you can see the middle one.
Yes, small mass with a bladder neck. That's what that will be at the start of section. That will be the first mass to come out and given for histopathology. Yeah.
Okay. So in first two scenario, you will do TURP with TURBT. In third scenario, in case sessile mass which is more than 3 centimeter,
yes,
probably will avoid and you will stage the procedure.
Yes, yes, yes.
So any other panelists want to add anything there or will differ with the views?
Yeah. I would like to ask a question, Nitesh. Do we have a scenario in which you have a known case for TURBT and same patient has a retention or significant symptoms and tuberculated bladder, and then you have to decide whether to do TURPT and TURP together? So do you have a scenario in the next few minutes, or we can discuss it here only?
You can discuss it here, sir.
So I'm now asking other panelists. You are the patient is a known case of CA bladder. I mean, he is going for TURBT only, but the patient is in retention. He has not clot retention. He is in retention because of prostate. It's a tuberculated bladder. It's an enlarged prostate, and the patient is worried about his retention. He has come to you for retention, and on ultrasound you found a mass. So, will you address both together or only the TURBT?
No, Anurag. The question here is with the previous history of TURBT, what was the disease?
No. I'm sorry.
We expected the NMIBC and has come for the resection.
No, I'm sorry. It's a new case, not a known case, known on reports only. On ultrasound, there is a mass, and the patient is worried about his obstructive voiding. He wants to get his TURP done, and you have found a TURBT thing before operation. You found a bladder tumor, and you are insisting that bladder tumor should be done first, and the patient is insisting that you get my retention relieved first.
No, I think you can do both the bladder tumor and the prostate together if your management for the bladder tumor is not going to change. But in the scenario which you have given, because he has come to you with retention, if both are resectable, they are resectable. You can do it simultaneously.
What about the implantation?
We'll go. What about
primarily? I think we should decide according to the merits of the bladder tumor, like Dr.
Arun sir, can you give mitomycin in these cases post TURP?
I think we give in all patients.
You are
Yeah. So the way you have described the first two scenarios, a small polypidal mass, a small mass with a bladder neck mass, without other details, I am thinking that they belong to a low risk category. Okay. They are NMIBC and they belong to low risk category, where I may think of doing mitomycin, but I am not a big fan of giving a mitomycin. I'll not bother about that. I'll just wait for the histopathology and just getting a benefit of mitomycin in a situation where you have found an incidental bladder tumor. I'll not bother because it will not be arranged and you have to indent it, you have to get it, and probably that's the time not an ideal scenario. So I'll not bother about mitomycin. I'll be bothered about having a good TURBT, so that a quick TURBT, and then proceeding with the TURP.
To conclude, I think we'll just conclude small polypoidal mass in case our endoscopic management, the final management is not going to change based on histology. Probably we can resect the mass if it is small, like polypoidal less than 3 centimeter. In case the mass is very big, sessile, we can go ahead and do TURBT, wait for the histopathology, and then decide on the further treatment. And regarding mitomycin, you can give mitomycin even if there is no hematuria, you can give in those cases. So we'll go to the next scenario. Yes, Dr. Aditya.
So my question is there to Arun Chawla sir, that is it, first of all, is it mandatory to see ureteric orifice always? And if one fails to do so, what are the options?
See, not able to see the ureteric. That means the first thing is when you have a TURP, you assess the whole bladder. That means the whole contours of the bladder has to be seen, which includes not only the ureteric orifices but as well as the all walls of the. Now, what you are asking is when the orifice is not seen in initial scopy. I don't know why orifice is not seen, provided it is the patient is not been operated for TURP or TURP or any other endoscopic infection which has involved the ureteric orifice.
Sir,
Or
I'll just
there is
quickly
a
like to.
gland, intravesical projection of the gland, which is making me difficult to reach and see the orifice. So I'm not able to
The
differentiate between these two.
primary situation can be the sometime orifice may get retracted into the trabeculations and the circulations. Many times patients are on long-term catheterization, so there is a lot of mucosal overgrowth, and that sometimes hides the orifice. And of course, the third scenario is there where large median lobe is making really difficult to bend behind it and see the orifices. So they
Yeah.
all.
So here the question is, if both are not seen or one is not seen. If one is seen, and probably I know that opposite orifice, I have some bladder wall changes secondary to obstruction. Probably I will not bother keeping in view that obstruction has caused the symmetrical changes in the bladder. If I have a situation where there is an intravesical projection of the gland, and I am because of technical reason I am not able to go behind that, then probably I'll keep a slower section of this intravesical portion and assess both the orifices again. But there have been occasions with me also where I was not able to find an orifice at least on one side more than a couple of times. But I have proceeded with the procedure without keeping in view that these are symmetrical changes, and because of some reason I am not able to find the orifice. But I have found the opposite orifice.
Keshav sir, anything you want to add to that?
No, it's sometimes if it's a very large median lobe, you will not be able to visualize this orifices. In that case, it's not necessary that you go behind that. You just take precautions that
Yeah.
you resect the median lobe first, then probably you will be able to see the ureteric orifices. You have to take precautions in resection of the median lobe that people will go to the groove between the lateral lobe and the median lobe first. In this case, maybe you will have to take the middle portion of the median lobe first, try to clear the median lobes, and then see the ureteric orifices.
So if despite doing everything, we are still really not sure where the orifices are. Cutting the orifice, is that really much of a concern, even if we have taken some chips through that?
Though, as long as you are sometimes when you find bladder tumors at the orifice, if you have used coagulation, if you have not used coagulation much, it does not make too much of a difference, even if you have resected the ureteric orifice at that point of time. If there has not been too much of coagulation where you are not going to make scarring and then give obstructive changes, it does not make a difference, even if you have taken one of the cut.
So to conclude, first of all, one should try to see the location of orifices to orient himself into the lower tract. Failing to do so, one can try to resect the median lobe and gradually and keep his resection maybe superficial while too much into the bladder, and relocate the orifice. And usage of less coagulating current will help in preventing charring and scarring around the ureteric opening. So this should be the approach. Next. So now it's about the technique of TURP. So I would like to go to Dr. Anant Kamath sir. So what is your preferred technique and why?
This technique will depend on the size of the gland. if it is a large gland, and if there is a median lobe, I will tackle the median lobe first. Or if there is sufficient gland, you think that even if there is no obvious median lobe, but there is a lot of gland on the floor, first thing is to cut there first to facilitate the irrigation. And if it is a large gland, once you have finished the median lobe, you start at 11 and 12 o'clock, 11 o'clock position or 1 o'clock position, one of the sides. And then keep cutting and devascularize the lobe. This is for a large gland. Devascularize the lobe so that the bleeding becomes less. And the remaining, the whole lobe falls on the floor. And once it falls on the floor, the resection becomes easier. So the step number 1 is to tackle the median lobe. Next, you go to either 1 or 11 o'clock position. I always retain a strip of mucosa on the 12 o'clock position. I don't cut at 12 o'clock position. And then if the gland is moderate size or medium size, then you keep cutting everything. Otherwise, you cut and run, make a channel to the capsule, keep on following the capsule, and then the gland falls medially on the floor and then starts resecting the rest of the gland. Finally,
Yeah, sir. Lalit Shah, sir.
See, every person has to decide whatever he is comfortable and confident with any practical. The basic philosophy in general, what we follow is that if there is a median lobe, it should be tackled one first, so that if there is any problem because of whatever reasons, at least the patient may become catheter free in spite of not being able to resect the lateral lobes. That is point number 1. Number 2, if there are large glands, then it is much better to do one lobe, at least median lobe and one lobe, rather than 2 half lobes. So that is what is there. Now, other things, whether you come from 11 o'clock to 6 o'clock or you go from 6 o'clock to 11 o'clock, it's an individual choice. It doesn't matter. I go from 11 o'clock to 6 o'clock.
But does it really impact amount of bleeding if one really tackles at 11 o'clock and 1 o'clock? We say the most of the vessels enter from there.
Somehow the other, I felt it doesn't make too much of a difference in our hands.
Anyone wants to add a quick point, something?
Aditya,
Yes, sir.
I think the technique that you do best is what you have learned as a resident. And in India, most of us have learned almost, I think, with very few exceptions, most of us do it in the same way. We first go to the median lobe or the bladder neck at 6 o'clock position, then go to right lobe or left lobe, and then go to the roof and then come to the apex. I think probably there is not much discussion to be done here. If there are some people who do it in a different way and they have got good results, so be it. I think probably technique depends on the individual, but because of historical reasons, we all follow Barnes' technique, because Barnes, when he was in a sabbatical from USA to India, he went in CMC Vellore. He demonstrated, and I think from CMC Vellore, that technique spread to all the rest of the all over India. That's why we are following that.
So that's the same point. I have never really seen live somebody doing 11 o'clock first, as far as I remember. Mostly we go median lobe, follow same lobe from down to above, then again to other side. But yes, the technique what works in one's hands best. Yes, yeah. Okay.
So, Aditya, are you suggesting floor to roof, 6 o'clock to upward? That is very uncommon, I think. And we usually use the Nesbitt technique. I start from 1 o'clock. Of course, after handling the median lobe, 1 o'clock down to 6 o'clock, and then 11 o'clock down to 6 o'clock. So if you start with the Nesbitt technique, which is very easy, you devascularize the gland, your lobe falls into the floor and makes another median lobe for you to eat. And then you go to the other lobe, start from 11 o'clock, devascularize the lobe, it falls down and it gives you another median lobe to eat. So it becomes very easy and very fast. For large glands, you should always try Nesbitt technique. Floor to roof is difficult, I believe.
Yeah, Dr. Chawla.
No, I think I follow the same way. We learned it from Dr. Shashidhar.
I think most of us in India follow almost the same technique to do TURP.
So we'll go to the next scenario.
Yeah.
This for Dr. Girish. what do you do when you are not able to proceed due to bleeding? The gland is very vascular. What do you do in those sort of cases?
Yeah, well, if there are two reasons why the vision becomes bad. If there are spurters, then the best thing is to go and stop those individual spurters, control the bleed, and go ahead. That is a easier scenario. The problem is when there are some vascular glands where the oozing is so much. For example, let us say the patient is on anticoagulant and the oozing is so bad that you cannot see anything. Then probably there are a few techniques which can be followed. One, you raise the height of the irrigation. Even though we say that to avoid TURP syndrome, we should not increase the height, but still in a situation like this, it doesn't matter. You tell the assistant to increase the height of the water so that the vision becomes better. And sometimes in desperate situation, you can pump also. Third thing, if nothing works, then you can put a suprapubic catheter so that the irrigation becomes much better and the good outflow. You go ahead and do it. But if nothing works, then I think you just abandon, put a catheter, put a traction, come out and live to fight another day.
Dr. Keshav, you want to add anything there?
No, I think what he has told is practical. We don't have anything more than that. Is because if you feel that you are not able to proceed due to bleeding, if you have done all the maneuvers, then you have to find some other day when you can operate on him.
No, sir, I little disagree.
Yes.
Without stopping the bleeding, you can't come out. Number two, not many people are using suprapubic way of giving access to the fluid for this. Majority of the time, I'll say almost in really all the circumstances, you will be able to control and stop the bleeding before you come out.
No, that's
there are many tricks which are available. I think everybody knows that. But the message should be not that without controlling the bleeding you can come out.
no, that is a situation when you are used all your techniques to control the bleeding. You will be able to do it most of the time.
Yes, yes.
But a situation when you're not able to do anything, if you have used all your techniques, then what would you do?
No, but the question here is, how can you expect the catheter to work in presence of bleeding? It won't drain. You give three-way irrigation, whatever you say, your agent will be sitting there with Tumisting and taking out the clots every time. This patient will go in again to the OR within hours.
May I add something?
Yes,
Sometimes what we find is when the patient is bleeding, then you put the catheter, Foley catheter, inflate it about to 40-50 ml and put the traction for 10-15 minutes. And you, like they say in renal bleeding and all that, you go out and have a coffee and a cigarette. Probably it works here also, and then the things becomes easier. That is number one. And many times it happens that it forms so clot over there, and because of the clot, once you evacuate the clot, the field becomes very good. This has happened in some of the cases with me.
No, sir. Again, Dr. Lalit, your point is correct. You put the catheter, give it traction. But if your traction doesn't lead to stoppage of bleeding, you don't come out.
And you have to go ahead. And do
Yes,
something.
Sir, I have two points in this.
Is there any role of hypotensive anesthesia in this sort of cases? We can try that. We can ask the anesthetist to decrease the pressure, and we can detect the gland. Probably once we go to the case, we should have better hemostasis there.
If he bleeds further, he will have hypotension.
Yeah, patient already has hypotension. that's why this has come up for discussion. No, but
anybody has any experience of hemlock or Sepgard or something like that to induce the clot in such situation and then evacuate the clots and make the things clear? I don't know. This is a theoretical possibility. I have not done. I have not seen. I'm just thinking wild.
Aditya, can I answer?
Yes, sir, please.
Yes. See, I think we have to clearly distinguish two situations here. Spurters versus oozing. Spurters, we have to stop. No amount of traction is going to stop it. We have to stop, full stop. Otherwise, we'll have to go in again. Whereas oozing, for example, let us say the patient is on ecospray. You're not taken history and you go and start resecting and then it starts oozing. You try to stop as much as possible, but you cannot proceed with the surgery any longer. You put a traction, you inflate it, put a traction, you rapid irrigation. Usually it stops. In such a situation, it stops. But then if it doesn't, then you have to go in and do a clot evacuation. That's a different thing. There is no other way of dealing with this situation.
Sir, in terms of control of bleeding, the most important point which I have learned from few surgeons, they once they can't see anything, they come to the bladder neck. They see whatever, if any, arterial sputter which are commonly there, maybe 11, 1 o'clock, or mostly around the bladder neck. Take control of those, put a balloon, inflate to 80 cc, and just pull it. It controls mostly. And
Yeah.
the second thing which I'd seen in Paris, actually, one of the center, what they had a 4 lumen catheter, so which actually had 2 balloons. So one balloon lies at the bladder neck. So first you inflate the distal balloon, you pull the traction, and you get it to the bladder neck, and then you inflate the second balloon, which is inflated in the prostatic fossa. So it has actually got 2 balloons, and there is a third channel which irrigates, and the fourth channel, of course, where the urine output comes. So I don't know whether we have that kind of catheter in India. So.
No, again, when you are talking about these catheters have a drainage lumen which is lesser, very small in size. They are unable to drain the clots.
The clots we have to evacuate, sir. Clots we have evacuated from the bladder, but we are facing a scenario where continuously some oozing is going in. So one option can be just take control of the bladder neck, because that part may not actually get compressed well with the balloon. Any bleeding happening in the fossa will ultimately die down. Even if it is arterial sputter, it will die down with the traction in place.
So one has to be familiar what is the acceptable color of effluent when you are using irrigation. That is important. Small mucosal bead and all that will stop. But if you have something which is giving a very high color, probably you can't come out.
No, but sir, Dr. Chawla, say for example, like you are saying, in the OT you are not able to control. You are putting the traction, and the outflow which is coming out, if it is forming clots again and again, how can you shift the patient out?
That's what I am telling. You can't shift. See, whatever literature you have seen, by the movement of the scope up and down, by rotating the scope both dorsally and ventrally, and by using the different ways of adjusting the flow of irrigation and hydrostatic pressure, keeping the bladder empty, in almost invariably all the situations, we should be able to control the bleeding. That's what.
I had this sort of situation quite a few times, and I think hypotensive anesthesia works. When the patient was normotensive around 130, 140, we can ask the anesthesia.
In the worst,
we can resect the tissue, and once we go to the floor, the hemostasis is much better, and we can do the resection and come out easily.
In the worst case, I would open up and pack the fossa.
So, sir, would anybody like to comment, like Dr. Shah also asked, role of hemostatic agents, also role of preoperative 5-ARI inhibitors, do they really help in the real-time scenario, and also starting dutasteride 1 or 2 weeks prior?
Can I answer, Aditya?
Yes, sir, please.
Yes. I think as far as the role of preoperative ARIs, I mean, it is very difficult to answer in a scientific manner, but my feeling is it is not possible. It doesn't work. Second thing is, it is not practical also. When a patient comes for TURP, how long are you going to put the patient on 5-ARI, ask him to come back after a few months and then do TURP? That's not practical.
Maybe a few weeks. I mean, large prostate, 90 cc, 100 gram prostate, a couple of weeks, I guess.
But then I think you see many patients who are already on ARI, 5-ARI, and
some
even they bleed. It is not necessary that it is something very automatic. So probably it is not practical, but then to give a very scientific answer will be difficult.
So I don't think yes, sir.
Role of hemostatic agents during surgery. Say, I don't have any experience during TURP, but I have done urethroplasties where the patient was hemophilic. I have used hemostatic agents there. The problem is, it is a very messy thing. You know, the hematologist was there. They give this thing, some fibrinogen or some product. You keep on injecting. The moment you put in this thing, it forms a clot. And you cannot proceed, because the moment it forms a clot, then you have to evacuate the clot there. And in TURP, it is even worse, because once they form the clot, you have to compulsorily go in and evacuate. So probably there is no role for hemostatic agents in TURP. Only thing some people use is tranexamic acid pause, intravenous injection, some put it in irrigation. and it may help.
The
But in worst case
psychological
scenario,
benefit.
you just go in and do clot evacuation, come out, and if nothing works, then you have to go and pack. But then packing is something which I don't think anyone in the panel or in the audience also has probably done in the last many years.
No, but Dr. Kamath sir, I have assisted him once in one of the cases.
You call senior panelists for the same reason. They have seen something which
Aditya?
we have not seen.
Sir,
can I add something here?
Yes, sir. Please, sir.
No, coming to the hemostatic agent, I have a interest of watching Professor Howard Lau in Sydney when I was there for a fellowship. He used to inject the vasopressin or noradrenaline without bothering about the cardiovascular status. And I have seen him resecting in 10-15 minutes only the big glands. And these glands, after the injection, 55 minutes, they are all white. Almost no bleeding at all. So that, and other is the use of what you have now, the phosphate and the aminocapturic acid and all that. That I have no idea whether people are using nowadays or not.
I think to conclude this, uh, in case if we are having a large vascular gland, we can try maneuvers like increasing the height of irrigation, inserting a suprapubic catheter. In case nothing is working, we can ask if the patient is normotensive, we can ask the patient anesthetic to decrease the BP and do some coagulation and resect further. And otherwise, we can have a coffee after inserting a catheter and give some traction and look after 15 minutes. If nothing works, then probably we have to do a hemostasis and come back after some time and see later. Open packing the prostatic fossa by doing a open prostatectomy is an option. We can do that as well in case the bleeding is very severe and patient is unstable. Role of hemostatic agent is not proven, it is doubtful, and usually it will make the clots very organized and sticky. 5-ARI role preoperatively, the role is not very sure, and how long to give, we are not very sure. Can be tried, but the role is not proven. We'll go to the next scenario.
A rectal packing works sometime, and keeping 2 fingers from below and pressing from down sometimes work. Yeah. So next.
Aditya, one more.
Yes, sir.
Even after packing, if it does not work, you can do internal arterial ligation.
So then it ends nowhere.
No, it works. You in desperate situations, you can do that.
Then case has gone out of realm of urology. So next, about the next slide, I'll just go quickly. We really have a lot of scenarios remaining, and we'll just want to have quick answers now, sir, with due respect. About large prostate, Dr. Chawla, sir, quickly, if you can tell me how large is too large, and how does one prepare himself for a large prostate?
Yes. Yeah, so it's a good question. So it all depends upon your first endoscopic assessment of the length of the prostatic urethra, and what you can say dorsoventral depth, and whatever is your truss guided or abdominal ultrasound guided size of the prostate, as well as the digital rectal assessment. So let us assume large means I have got 100, 120 or 150 gram of gland. My approach will be to assess the gland endoscopically and then take a call. It will be, a patient will be explained that I am going ahead after the endoscopic assessment, either into a single stage section, depending upon the condition, or a stage section, or open. Everything will be spoken and consulted to the patient. So again, if I am using endoscopic technique, I won't be bothered about removing the gland, everything in one sitting. I'll be planning what you can say sector by sector, or a unilobar section if the gland is big and I can't finish in 60 to 70 minutes. Maximum, so I won't go more than 75 minutes.
So what is your objective criteria of large gland? You are saying endoscopic, but I mean just visual appearance. How do you assess?
It is a combination. It's a combination. What may look on a single dimension, if you increase the dorsoventral depth and the intraurethral gland, it may be very big gland. So
I want to know, how do you measure it intraoperatively? Do we have any objective criteria to say okay, this is it and this is big. I mean, this is this centimeters or this length of scope length.
So let us assume you want to see the parameters. I'll say any gland which is where the prostatic urethral length is coming more than 4 centimeter. Ultrasound weight of the gland is fixed as 100 plus and all that. And I have a dorsoventral depth also coming 4 to 5 centimeter. These are the glands where I just pick a lower section only. I won't be worried about. I'll be worried about in section from better neck to the apex on one side going to the.
Dr. Girish sir.
I'm not talking about the open indication of open. I'm
No,
just
no,
talking
not
about
so.
endoscopic management.
TURP, yes, sir. Only TURP. Girish sir.
Yeah. See, there is no definition of size. There is no definition of what is big, average, and small. It all depends on the experience of the urologist and his own skill and capabilities and confidence. So there are two steps. First, before surgery, he should see the size of the prostate by digital rectal examination as well as on ultrasound, and should know whether he's capable of dealing with it or not. Something like, for example, 170 grams. There is no question of taking a decision intraoperatively on that, because he knows beforehand that he's warned that he will not be able to do it. Second thing is, sometimes if there is a preoperative assessment is ambiguous, and intraoperatively you find that visually, it is all a visual impression. Visually, you see whether it is possible for you to tackle or not. Then you take a decision whether you can go into TRP or not. There is not. I don't think there is any size criteria. 1 year old, I mean, person with 1 year experience versus 10 years experience, the size, everything differs. But suppose, let us say you are caught in a situation where you have promised the patient that you do TRP and intraoperatively you find yourself in a soup because you are not confident, then at least do a channel. Do, if the bladder neck is elevated, or do median lobe. They are the easiest to do and also the most effective. And do a little bit of channel and come out. Save the situation. Only that's what you have to do.
Sir, like in our case, Keshavmurthy sir, my question is to you. Like in our case, like all my prostate, I do their ultrasound by myself. Before surgery, I really ensure that I do the ultrasound by myself. And especially if the sonologist has given large gland, 60, 70 plus size gland. So it creates a correlation when I really go in endoscopically. And so do you think, is it a good strategy for younger urologists to correlate themselves? Because many times radiologists will exclude median lobe. Sometimes the median lobe length will make prostate look like 120 cc, but it will be actually 60, 70 just with large.
Very true. That is why a lot of urologists are training themselves with ultrasound now, because that is very essential. Because apart from your digital rectal examination, if you are able to do your transrectal ultrasounds also, you will definitely know what is the size, because what the radiologists will look at the size of the prostate is much different from what the urologist will look at. Some people will just exclude the median lobe, and if you include the median lobe into a dimension and then multiply that by 0.6 or 0.7, you will have a large prostate. But once you go inside, your lateral lobe may not be much. It's only the median lobe, and you find that the urethra is long, and because he has taken the dimension to be long, he will give a false reading of that it is 120, 130. It may not be so. So it's definitely better that the urologists learn to do the ultrasound and measure their prostate by themselves, along with the other ways of measuring the prostate.
Dr. Kamath sir, so
there is
what will be your cutoff criteria or set of criterias where you decide this case is not for TURP, we have to go for some other alternative method or maybe a simple prostate?
correct. It is all depending upon your capacity, but I would think that average urologist should stop at the level of 70 grams. An average urologist. 70 grams is an average capacity. If it is a 70-gram gland, then I think you should be reasonably able to do the job justice to the. If it is above 70 grams, then you have to decide as to you do it in one session or two sessions, as Dr. Arun Chawla said. If you still want to do TURP, that is why I prefer always epidural anesthesia, so that if the larger gland, you always give epidural anesthesia so that you finish one lobe in one setting, come 48 hours later and do the other lobe, or at least 3 days later when the epidural catheter is there. So 70 grams should be a reasonable criteria, or 60 to 70 grams should be the cutoff for an average urologist.
Sir, I have a question. Fixing only one criteria may again be an issue because grams on ultrasound is a very subjective finding put to us by radiologists,
Yeah.
or the volume.
The second aspect is that when you do ultrasound yourself, the gland, even if you do a cystoscopy, it may intra-urethral enlargement may not be big, but the lateral enlargement will be more. So the anatomy has to be studied well with the ultrasound. I agree with your point that if you can do an ultrasound yourself and find out where the enlargement, so many times the anterior gland is more, sometimes it is posterior enlargement. So median lobe is, of course, anybody can make out. These lateral enlargements, you keep on resecting, the gland keeps on popping at you. Even if you are resecting, you don't reach the capsule. This sort of, there is not much of intraurethral enlargement, but there is a lot of lateral enlargement.
Two quick questions.
You are trying to, some other input you wanted?
Sir, two quick questions, one to Dr. Yadav and one to Dr. Lalit Shah, sir. So, Dr. Yadav, do you think injection leuprolide pre-operatively will help in terms of gland shrinkage?
No, I don't think, and I've never used. And some time ago, you asked about dutasteride. That is fine. And most of the patients are already on dutasteride if it's a large gland. And maybe it helps in reducing the bleeding. But
there is no evidence to prove actually. There is no evidence that supports except some pharma-sponsored studies.
No. It shrinks the gland. We have seen in the past patients who were 70, 80 gram prostate 2-3 years ago, and now they have come, it is only 40 gram prostate. So it shrinks the hyperplasia part. Now, about the size of the gland, how big is big? My cutoff is 100 grams, but not that I don't take more than 100 grams for monopolar. I take up to 150, but 100 grams means my cutoff is for arranging blood. So if it is 100 grams, I arrange blood. Below that, I don't arrange blood. And median lobe part is very important because the sonologist will report a large gland and it is only median lobe. So you must be happy. You must be happy seeing a median lobe for 3 reasons. One, that it is not as big as the sonologist reported. Second, median lobe, if you take out and if you have some problems, you leave other, the patient is likely to pee. And third, median lobe gives you best results in patient satisfaction. If you have a median lobe, you are sure that this patient's symptoms are because of prostate, and TURP will help.
So, Dr. Shah, sir, in terms of simple prostatectomy, do you think now there is any role of Millin's retropubic versus Freyr's prostatectomy, normal conventional transvasectomy?
You mean to say open prostatectomy in such large glands? Somehow the other, my personal preference is because I really love monopolar TURP. So my preference has always been to do the TURP. And I believe that rather than an open prostatectomy, a 2 TURP are probably better. If I'm a patient, I would like to have that. And that's how I convince and counsel my patients that we would do, if required, it may be in a staged one. And most of the patients are happy. And it has happened many times that there have been some patients who are more than 10 years where the large gland was there. We have taken care of the median lobe as well as one lateral lobe, and they are doing fine.
So to conclude on this, we have to really rush through it, sir. We have many topics untouched. So to conclude, assessment of large gland should especially be done by the urologist by himself if they can go and see on ultrasound, and they can really correlate radiological versus endourological, what is a large gland, and it helps in planning. Staging a TURP should always be an open option. Whether somebody gets stuck due to time or due to complication, that option should be exercised as and when needed. The role of the open prostatectomy is still not out, and it can still be lifesaver in many situations. And the role of leuprolide, actually we have used in few cases, and it really makes gland very soggy. But I don't know whether it helps in preventing quick shrinkage. Does it give or does it reduce bleeding? I'm not sure. So going to the next slide.
Before you take the next one, I will just make a small comment. I know some people who are using bicalutamide also pre-operatively for this. I don't know how justified it is or not it is, but yes, there are people who are using bicalutamide for this. Yeah, just a comment.
Right.
This Dr. Girish, You have got a large gland and the drainage is not very good. The bladder is getting rapidly filled. So what you will do in such situation?
During surgery, correct?
Sorry?
During intraoperatively, the
Problem, yes.
there is
If
no
you got a
good
large
out.
gland, it is
Yeah.
not draining well.
Yeah. Then you just see the outflow of TURP sheath, whether there is any blockage. I use a 10 or 20 cc syringe to flush and to remove the sheath and clean it up. That settles the matter so many times. If that doesn't work, then the only thing left would be, of course, if the bleeding is too much, then naturally clots are forming much faster than what I can evacuate. I have to take care of that also. Or in some situations where nothing works, then I put a suprapubic rotor cannula. And I have a rotor cannula and I put it and it's quite useful. So it helps in such situation.
We'll just ask each question to one panelist unless it is very important. If anyone wants to add something, please let us know. Anyone wants to add anything? Yes, Kamath.
You can apply suction to the outlet.
Suction to the outlet. Okay. Anyone wants to, anyone else would like to add any other point? So to conclude, in case the drainage is not proper, we have to flush the PR sheet. We should see whether it's not getting blocked because of the clots. We have to clean it and then we can give some irrigation and see. If nothing is working, then probably uterus cannula or a suprapubic catheter can help. And we can also use suction there. So coming to the next scenario, Dr. Aditya.
Yeah, Dr. Girish, if you can quickly give troubleshoot. We started the TURP, but nothing is cutting. 1, 2, 3, 4, 5. What one should check and how does one go?
It happens because suddenly I realize that I have been stupid. I have not even connected the cord to the corded machine. That's the commonest reason why it doesn't work. Second reason why it doesn't work is instead of using glycine, you are using normal saline or using something. The solution is wrong. Third thing is probably the patient plate. You look at the patient plate. These are all the reason. Usually it gives an alarm, but if it doesn't give an alarm, it doesn't cut. Look at the patient plate, why it is not cutting. And other than that, your loop is not been fitted properly. It is not making contact, or your cautery settings are not right. Maybe your cutting is too low, or your cautery settings, like for example, it is in the spray mode or those modes, soft cut mode, etc. You do those tinkerings. Usually, then it works.
Sir, your loop has broken and you don't have a spare loop.
Loop has broken and no other loop available. Then as a phase gesture, probably you do a bladder neck incision using Collins knife. I think that's what I would do. At least you'll be able to pass urine.
Any advantage of thick loop over thin loop?
I have no idea.
The thick loop is sturdy for sure.
Yes, but I don't think it makes too much of a difference in TURP because all of us have got only one type of loop, whether we do TURP or TURPT, and it works.
If it is a used loop which is thin, that is the loop which I keep it for my bladder tumors.
Okay. Okay. Next, Dr. Nitesh.
Now, one suggestion to all the freelancers, you are telling that a lot of freelancers is to have one spare for everything, and that checklist should always be before you start every case. You should have the one spare frequency cable, one spare loop, and of course, you have to see whether your place has got a generator or not when you are going to support your cautery.
Okay, so once we are reaching the capsular limit, Dr. Kamath sir, and there are contraction of capsular movement, what does it indicate and what is the inference from it?
That shows that you have reached the capsule.
Okay,
the gland does not contract, but the capsule contracts on stimulation. That's the time to stop resection in that area.
So those are actually the intraprostatic muscle fibers which are compressed in the last layers along with the capsule. They have some contraction. The adenoma doesn't contract, of course.
Let us not define it anatomically, but that's the limit of your resection. If something starts contracting, you should not resect beyond that.
Okay. Next, Dr. Nitesh. Okay. So what is the Dr. Keshavmurthy sir, is the concern of operator jerk in QRP is real, and how much
No,
was it can do?
you can get a TUR jerk only when you are very close to the bladder neck or close to the orifices. If your resection, the gland is extending intravasically and you are trying to resect close to the bladder neck and very close to the orifices, then you can get a jerk. If
So
it's
jerk, does it make any much of difference? I mean, except keeping bladder half fill, one should not have a very full bladder, because jerk can really cause explosion of bladder if it contracts suddenly on full bladder. Because we are anyways in the prostatic area, so should it be really much of a concern?
no, if you are resecting, if you are it's an intravesical lobe and you're resecting there, it makes a difference. You will perforate. But if you are generally in the prostatic fossa, you generally will not get a obturator jerk.
What one should do in such scenario if they are facing jerk now?
No, if you are facing jerk, then if it is repeatedly happening, then you ask the anesthetist to give general anesthesia. I don't think it should be a problem with a patient under general anesthesia with muscle relaxant. But I have not had a obturator jerk when I'm doing a TUR, so it's not very common. It's only that if there are intravesical extension and you're trying to resect the lobe there, then you can have the obturator jerks.
Maybe the operator block is also an option if that can be given.
But you would not have anticipated this, and you operator blocks you will have to give before you put them onto lithotomy. You can use ultrasound and give blocks, but after that you will have to use blind technique of giving an operator block.
Right.
Aditya, unless like TRBT, if the gland is not much significant in that area, you ignore that area and resect at other places. If you keep, there is already some perforation, and if you keep irrigating that area, undermining the bladder will be a problem. The irrigation keeps on increasing that particular area.
Dr. Girish, you want to add
Yes,
something?
Sir, Girish, sir.
Yes, I have faced obturator jerk while doing TURP. And surprisingly, even when I've been away from the bladder neck, even then I have faced this, which is not common, but I have faced this. And as far as the treatment is concerned, I think every urologist should know how to give obturator block. It is easy. You don't have to change the position of the patient. Patient is in lithotomy, and it is a blind procedure. You don't need ultrasound. You don't need any nerve stimulation, nothing of that sort. You can give obturator block, and it almost always works. So, and how to give obturator block? It is in the suprapubic area. Some people have given transrectally, but I think what I give. And there are enough references in literature, probably Indian Journal of Anesthesia, etc. You type in obturator block, and it's very easy technique. Just use a spinal and give it.
What anesthetic agent you use for operator block?
I use lignocaine.
Lignocaine only, not bupivacaine or other.
No. I think I have used lignocaine because it works for about 15-20 minutes. Bupivacaine, if you are anticipating something longer, I think you can use bupivacaine. But I have used
in the bladder tumors. Okay. Next, Dr. Nitesh.
So this question for Chawla, sir. You are doing a TURP and you have opened a sinus in early part of the surgery. What you will do?
Early part of the surgery means that you have gone technically wrong. You have gone deep, and you have entered into the sinus. now coming even if you have entered, now what we have to do is you have to stop the bleeding. How the sinus bleeding will be stopped? So you have to maneuver your resectoscope in and out to find out where exactly the bleeding is coming. Usually it is in the form of the ooze, and probably you have used your wisdom to get the flow adjusted and stop the bleeding. So you will have a loop which you are seeing the opening of the vein with your flow adjusted and the resectoscope rightly positioned. You will have the loop adjusted on the wall of this sinus and the tissue on one side, coagulated, and then you come to the opposite side, again the sinus wall and the tissue and close. So this will lead to the closure of the lumen, and then probably you can decide whether you can run the coagulation loop over the lumen also. Whenever you are closing this sinus, you will ask the patient to cough and see whether it will lead to more bleeding. You will decrease the flow of your irrigant to see it is not opening. But this is the way I do. Number two, at this point, usually when you open sinus, you will have one, what you can say, vasavasorum or arterial spurt also, which will be tackled separately. That has to be tackled first. Then will be the opening where I'll go first along the wall and then to the lumen.
Anyone wants to add anything there? Should we try to
Yes.
coagulate sinus bleeding, or
Yeah,
any other
can I?
comment from any other panelist?
Yes, yes.
No.
Girish here, I could make some comment.
Yeah.
Yes, sir.
Yeah.
Yes, sir.
I think opening a sinus in the early part should never be done because you have to be very careful. But once it is done, I think you try a loop electrode, but if it's not possible, use a ball electrode to coagulate. You can't press too much, but you try to coagulate. You can see the fat gone burning everywhere. But the problem is stopping a sinus bleed is extremely difficult. You read in Marmars how to stop it, but it doesn't work. So if the bleeding is very bad and your vision is very bad, I think you have to abandon the procedure at that point. Put a catheter, traction, and stop at that point.
And keeping suprapubic catheter is an option in terms of keeping pressures low, because the absorption will be more with higher pressure.
But the problem is
Go for
vision.
that.
Aditya, problem is vision. He keeps on bleeding. Your vision may be good because you are using a lot of irrigant and a lot of this thing, drainage also. But the patient is losing blood.
Aditya, I have a point. The problem with sinus is not only bleeding, but fluid absorption. These are two things.
Yes.
So bleeding will be more if you keep the pressures low. In a full bladder, the pressures will be high, bleeding will be less, just like in laparoscopy, but absorption will be more. So you have to choose between the two.
So of course, the blood can either come in or go out. So
yeah. So if you keep pressures low, you will empty your bladder or keep suprapubic, the bleeding will be more. So don't keep pressures low. Now the question is absorption. So you go to the other side of the gland. Wherever you open the sinus, don't tackle it. Go to the other side of the gland, start resecting the other lobe. If the patient is stable, if the bleeding is not much, you keep your attention to the other side of the lobe. So by pressure of the sheath, the irrigation, inflow and the bleeding both will be minimized from the sinus. And do not try to coagulate the sinus. It does not get coagulated. As Dr. Chawla said, you coagulate the side of the tissue on the side of the sinus. Don't coagulate on the wall of the sinus. Sometimes there is an arterial spurter along with the sinus. That arterial spurter can be the reason for bleeding. Sinus cannot be coagulated. And if you don't have anything, then you come out and give traction. That's all. But try to finish your work from the other lobe. Do not look at the sinus. It will increase the absorption.
I think, Aditya, to add, I don't remember the publication, but one author has published his technique of taking a chip from the side of that perforation where the sinus is there and inverting into that fossa and trying to make a pressure of that. I'm forgetting the name of that publication. Somebody has published that also.
No, it's written in Marmars also.
It is in Marmars. It is in Marmars.
No, it may be mentioned in Marmar, but I remember that the person who popularized this technique.
But it's not easy to do.
Yeah, I think it is theoretical.
How does the chip remain there? I mean,
you don't resect the whole chip. You develop a flap.
Still, it has option of going back to.
No, Aditya, I think we should not even discuss that because I don't think anyone can do it. And I don't know how Marmar also wrote that.
Yeah. Dr. Nitesh, next.
Okay.
So there is a lot of controversy about, leaving, one should then do a 360-degree resection or leaving an anterior strip of gland. Dr. Kamath, if you can quickly comment on that.
Yeah. This strip of gland that primarily the issue is that we go by the dictum that anteriorly the gland is very less. This anatomy has been proved in several. So there is no.
There's an anterior commissure, so that's where both the lobes join.
Yes.
No adenoma is there.
Yes, and this will act as a landmark for you for mapping your resection. Number 3, Supposedly this is one of the caveats to prevent the bladder
Contracture.
contract.
Sir, I have a counter question to this, just quickly. In HOLEP, we generally go all around, and we really don't see many contractures developing there. Though this leaving the strip is popularized with the idea of reducing the contractures, so how does it work in both the scenarios?
I cannot answer that question. Maybe with the energy that we use in laser is different, and electrocautery is a different sort of energy, and its effects on the tissues may be a little different.
Any quick
Aditya,
comment, Keshav?
No, see,
I don't.
Aditya, may I comment?
I don't leave a strip of tissue at all. I resect completely. I don't find any difference in the bladder neck contracture. If it has had to happen, it will happen. I don't think this leaving a strip of tissue anteriorly is going to prevent bladder neck stenosis.
Yeah, quick
Aditya,
point
can I
from
add?
Aditya,
Girish,
I
sir,
can understand
and-
what
yes.
probably laser you are doing
sir.
is usually in the larger glands. So probably that doesn't make to the bladder neck stenosis. While TURP you are doing also in a smaller glands as well. So probably overall numbers that you see may be making the difference.
So are contractures more common in a smaller gland?
Yes,
Yes.
Can I add, Aditya?
definitely.
Yes, sir.
Yeah, so the etiology behind this bladder neck contracture is a microfenestration in the capsule, especially at the bladder neck, leading to exercise, which later forms a scar around the bladder neck. And this is commonly seen in smaller glands, but can be lesser incidence can be found in a moderate to larger size gland if your section technique is poor.
I think we go to next point. Next slide.
So the next question is for Lalit, sir. We have got a prostate with gland hanging behind the veru. Can we resect a gland which is hanging behind the veru?
So we need to see the sphincter is distal to that. And leaving the tissue at the apical area, you have to go bit by bit. And that is what I said with the suprapubic pressure test, how much is to be done there, because that is the where the possibility of incontinence is there. So it is better to leave little bit tissue, but which is reasonably sufficient enough to pass this one. Distal to veru, you in larger gland, you have to resect. There is no question about that. But then you can undercut it rather than overcut it.
So what are your tips to resect beyond veru? Do you do reverse cutting or a finger inside the rectum? Do you use all this maneuver?
Yes, I do. Depending on the situations, I do both the maneuvers.
Okay. Dr. Keshav, you want to add something there?
No, you just before you start resecting, you have, when you do a good cystoscopy, you can definitely see the landmark of the sphincter, and you have to have a visual impression of where the veru is in relation to the sphincter and how much gland is in between these two. So if you have that visual impression, then the maneuvers of lifting that, putting a finger into the rectum and lifting, and then you can make retrograde small cuts to clear that hanging tissue which is projecting beyond the veru.
To conclude, we can resect the gland which is hanging behind the veru, but we have to be extra careful. And we can initially, when we're doing initial cystoscopy, the sphincter and the relation of veru with the gland, and then we can go and use different maneuver like putting the finger inside the rectum, or do reverse cutting, or take small chips to resect the tissue beyond the veru. We should always do undercutting, means less cutting, or on the side of cutting less rather than overcutting that area.
The gland beyond
Go
the
to
veru.
next scenario.
Yes. The gland beyond the veru can also be gently lifted like we do in bipolar enucleation. So just the mucosal cut, and with the push of loop, it can be lifted also, like how we do in bipolar enucleation.
So, Aditya?
Yes. So, Dr. Kamath, sir, this question is for you. When do you, I have seen you completing it so beautifully, so I had to ask it to you. How does other urologist understand that he has completed the resection? Because many times we really don't reach to the capsule, and the moment we go in again, we see more gland is still popping into us, like from the lateral enlargement, as you suggest.
Like once we give
So
wash,
what will be
again and again the gland is falling back.
Yeah, this is to one important thing is that you assess the prostatic fossa with the same amount of bladder volume. when you see the prostatic fossa on an empty bladder, you will find that a lot of tissue is coming inside. And when large amount of bladder this irrigation is there in the bladder, you see a flat. So you have to do a trade-off in between the two. You have a moderate amount of irrigation in the bladder, and you assess the prostatic fossa. And at all times, you go and see not by the amount of tissue that hangs, but the quality of tissue. You have to see that you have reached the capsule. If you have reached the capsule, then that is the time to stop. And how do you know? This is a matter of experience. What is a gland and what is a capsule? Gland is something like bread, and it for in appearance, and capsule is something which is like a fibrous sheet, like a mat. So if you have reached the capsule, then so many times you find that residual tissue is there because you see it on the empty bladder. So
Keshavmurthy sir.
Yeah.
So is the, because in TURP we are lot of time constraints are there, and we presume that 75 and more generally should not be taken for TURP. So in a 90 minutes time, if you already think we have resected 60-70 grams of gland, is it really important to try to reach to the capsule? I have resected enough. Is it not good enough for the patient?
No, if you are telling that you are doing a TURP, you are supposed to remove what is complete. You have to completely remove it. But if time is a constraint, if the patient comorbidities are a constraint, and you have to have the patient to void, it's not necessary that you have to go to the capsule and remove the whole of the thing. There's something called palliative resections. This you can channelize and do, and it may not be a complete TUR, but it will give the patient the relief from his retention or from his voiding symptoms. But if you want to tell that I have done a complete TUR, you have to make sure that you remove most of the gland up to the capsule and see that you remove all the gland so that he does not have recurrence of symptoms and he is free of his problems.
I would like to just share a quick experience of Pillai sir. He told that in 90s when the TURP started, people got their gland in penicillin bottles. Only
Correct.
that much was removed. So, Girish sir, anything you want to add?
No, that's all. I think 3 points. At the end of resection, you keep your resectoscope at Veru. You should be able to see part of the interior of the bladder. Ideally, the complete interior of the bladder, but it may not be possible, at least part of it. Second thing is, keep it to the Veru, and you should see an opening on either side of the Veru. That means you have removed the apical lobe completely. And just go to scan to the right side and left side, you should be able to see capsule. It may not always be completely a resection to the capsule, because TURP is a very deeply unsatisfying surgery. Because even at the end, you say you have finished everything, you call another urologist, I'm sure he will be able to remove a little more gland from what you do. Because it is a surgery like that. So once you accomplish these things, that's the end of the surgery.
Yes, Dr. Anurag, you want to add something?
I think the beginners should know that it is most important to remove tissue from the apical part, because it is a funnel. If you widen the wide part of the funnel, you are not going to achieve anything. You have to widen the smallest part of the funnel. So most of the times we are interested in resecting the bladder neck area. You must not spend much time there, and you come to the apical part and relieve the obstruction there. If you keep cutting in between, you keep making the tissue fall into the floor of the gland and making the patient more obstructed. In a partly done TUR, a patient who was not in retention can become in retention in the postoperative period. So it is important to cut in the apical part.
Dr. Venugopal has commented, he's saying that it is only, one needs to only remove 30 to 40% gland in terms of removing obstruction. But at the same time, what decides the recurrence of gland after TURP is the adenoma we leave behind, because adenoma increases in size much faster than the natural gland. So normal gland leaving behind is okay, but the adenoma will quickly come in 2 or 3 years time, even if we have removed 40%, 50%.
Aditya, one more thing. The half resected lobe is more likely to bleed in the post-operative period, not necessarily in the hospital, even after going home.
Yes, infection.
That is also one of the important aspects.
Yes. So Shah sir, what is your preferred method of hemostasis, loop versus ball electrode? What is your method of hemostasis?
I prefer loop.
Okay. Pinpoint
Pinpoint
coagulation.
loop. Yeah. Only loop.
Anybody prefers ball in
Ball.
any particular
Always,
situation
always
except
ball
the
in the
sinus
end.
people use?
Always ball in the end. While you are
Okay.
cutting with the loop, you keep coagulating in between, but in the end, always use a ball to finish off all the
So
bleeders.
generalized coagulation, or but if the
No, no, only
pinpoint
the
bleeders
bleeders,
are anyway
all
stick,
bleeders, all
okay.
pinpoint bleeders, even smallest, to
So
keep
you prefer ball over there.
ball electrode at the end. And I use the ball electrode to make bladder neck incision also in the end. I don't use Collins, I use ball electrode with cutting current, and it gives a very, very nice and safe bladder neck incision.
So I guess it comes to the personal choice and experience of the person, and between loop versus ball. Dr. Nitesh, you can take up the next one.
So now we have completed, in between the surgery, we are having lot of disturbances, electrical disturbances. So how can one suspect that there is a leakage of current? Dr. Girish, what are the different things you notice during surgery that there is a leakage of current? One is we can see a lot of disturbance there in the current, and should we proceed if we are finding uh, such things? Dr. Girish?
I think the most common thing that we see is disturbance in the visuals on the monitor. So you can't see the visuals very
Asking
well.
is in between.
Yes?
Yeah, disturbances during the visual. We see a lot of
Yes. Visual disturbances. When what you see on the monitor, there is a lot of, the movements, pixelation, something like that. You know that there is a leakage of current. The second way in which you know is many times when you are operating as a right-hander, the place where you hold the resectoscope using your thumb and the finger, that point becomes very hot. That's another thing. And third thing is sometimes you can see the sparks. So these are all the situations which should be red flagged and
will you
very
proceed in
careful
this
about.
sort of situation? Like if you're just having a fixation here, what we are seeing on the screen, you proceed or you just check your current, and in case nothing is working out, you will go ahead and do the surgery, complete surgery.
Hello, sorry, I could not hear you.
No, in case there is a lot of disturbance, what we are seeing on the screen right now, whether you will
Yes.
proceed with the surgery because you are suspecting a current leak here, whether you will proceed with the surgery or you will abandon the surgery.
I have proceeded with the surgery in the past whenever there have been disturbances. As long as the disturbances are not so bad that you cannot see anything, you will be able to see. You do some minor adjustments. You reduce the cutting, for example, cutting to 100 watts and coagulation to 40. That's what I usually employ, and I proceed with the surgery. Nothing happens.
But the stricture rates and all, in case the leakage
Now,
is there, you think
another thing that can help is to change the loop, or if required, high frequency cord, and sometimes it helps.
Correct.
I think if
Because
the
if
disturbance is
repeated
on
use,
the
the port becomes looser. The port which fits into the monopolar electrode, the port of the
Yes.
frequency cable becomes black and
Yes.
wider.
Yes.
So that's why it's time to change the frequency cable.
yes, Dr. Anurag, you
Yeah, I think if there is a disturbance only on the monitor, it's a different story. You have to change the electric point of your cautery and of monitor. Sometimes they are connected to the same wall outlet. So change it to a different plug point. That is the
yeah,
most important reason of disturbance in the monitor. If there is disturbance is kind of sparking in the plug, sparking in the loop, then it is a different story. You have to change your the cautery cord or the loop or see the fitting. But if you're talking about disturbances on the monitor, you have to change the cautery and the monitor to different plug points on the wall.
yeah, I agree with you. Many times the disturbance actually happens because both cautery and the monitor are connected in the same extension code. So probably changing the flux sometimes helps. And in case the disturbance was small, probably we can go ahead and do the surgery. But if it is very large, then probably we have to abandon. So coming to the next scenario, doing a re-TURP, what are your tips and tricks? Keshav sir, what are your tips and tricks for doing a re-TURP?
No, when you want to do a re-TURP, you again have to see the landmarks. The initial one would be the sphincter. If the patient is continent, you have to see the sphincter first, then look at the veru, and then when you go inside, you can find residual lobes, or you can find bladder neck contractures, all those things, and sometimes it will be bladder neck stenosis. So you'll have to manipulate in such a way, or maybe you'll have to make initial incisions for the bladder neck to go inside, and
There
then
is one lobe there, but you cannot see the veru. You cannot, because many a times you see in re-TURP the landmarks are lost. So what you will suggest in those cases?
so the important landmark would be the sphincter. You have to know where the sphincter is and then go inside. And then if you're not able to see the veru, that's all right. But if you are able to see the bladder neck, either in the form of stenosis, or you're able to negotiate the scope. If you're not able to see you're not able to negotiate the scope, you can make incision on the bladder necks, and then you can go inside. And then you will have to resect what is the residual lobe which is left. But if you are not able to go beyond that, then you'll have to put in a guide wire to see if you can pass, and then try to use smaller scopes to go inside to see the
So we are
anatomy
talking
first
about
and then
bladder
resect.
stenosis. There is a gland enlargement there.
No,
So,
if there is a gland enlargement after you have gone inside, assist inside, and then you can resect the gland.
so we can just resect as usual what we are doing. There's no, you are not going to change your technique.
You're not going to change the technique, except that your distal limit, if your veru is not very obvious, then you have to keep your sphincter anatomy very clear and then resect it proximal to that.
Chawla sir, do you want to add anything there in case of
Yeah, see here a little bit addition only. When you have already a gland which is resected, that means you have to be very cautious. Any chip, first chip, if it is deep, now you are gone, you are into the sinus. Because your gland will be asymmetrical, thinned at some places, big at other places. So heaped up tissue at one place, and almost capsular section has been done at some other place. So the first thing will be preserving the distal landmarks, which will be the sphincter and the viru. If the viru is if not seen or if flattened, like finger in the rectum and raise the floor to see where it is. Usually seen somewhere flushed along the floor, and then keeping the same finger, I'll assess the tissues on the floor, where it is thick, where it is thin. I'll go to a very safe, going with a very thin section of the loop, as compared to the you can say the normal at the first section. Just be very careful. Even with a small one chip only, you will be deep.
so, so in case of re-TURP, identification of the landmark is very important. In case the landmark is not identified, we can see the sphincter, and for veru, we can insert a finger into the rectum, we can raise it, and sometimes the flattened veru can be seen. We should take thin chips, and we should not take thick chips, especially on the floor, and we can resect the tumor as usual. So we'll go to the next scenario. Prostatic abscess. So, Dr. Girish, what are your tips of deroofing a prostatic abscess? How deep we should go, and what are ways of achieving hemostasis? Because we see a lot of granulation tissue, especially on the floor, and they keeps on oozing. And what is your preference, whether you will put a catheter or SPC in patient with prostatic abscess?
In prostatic abscess, you do a normal TURP. There is no special way of doing a prostatic abscess. You identify the veru, you identify the bladder neck, go on resecting. Most of the time, you will find the prostatic abscess towards the apex rather than at the bladder neck. And towards the apex, mostly at between, say, 4 o'clock, 5 o'clock position on the left side, and 7 o'clock and 8 o'clock on the right side. So you go on deroofing. At some point, you'll hit the prostatic cavity. It keeps on emitting pus, draining pus. Bleeding is not a problem because most of it is a necrotic tissue. In fact, the blood loss is very little. So don't worry about the bleeding. Only thing, sometimes you are scared whether you have entered the rectum or some surrounding tissue because such big cavities. On pus, don't worry. Hemostasis is never a problem. At the end, I just keep a catheter. I don't keep a SPC. Give a wash. Don't give too much wash because it causes bacteremia. but you complete the surgery and then put a Foley's catheter and complete.
Dr. Anurag, you want to add anything there?
Yeah, I make it a point to differentiate between a young patient and a prosthetic age patient. If an elderly patient, I'll do a regular TUR and the abscesses are also dealt with. And many times in a routine TUR, you find micro abscesses or a little bigger abscesses also, which are not so inflamed now. But if the patient is presented as a prosthetic abscess, febrile, young, you must do only deroofing and don't try to remove the whole of the prostate.
So anyone else differ with these views?
I will anatomically, the prostate location, the abscess location has been defined pre-operatively. So I will do a single cut and keep on deepening the cut with loop or sometimes Collins knife until you reach and the pus starts oozing from that particular point. And I take that point as the reference point and then keep on enlarging that particular opening so that you have adequate drainage. Once the drainage has been adequate and a reasonable wash has been given in the prostate cavity, I close the procedure at that. I do not do any aggressive resection at that point because majority of the size that has been given in the ultrasound, it shrinks post-operative.
So to conclude, a pre-op anatomical location of the prostatic abscess is must. Once we know the abscess, probably we can deroof the abscess, and majority of the time the prostate sinks once we do. So majority of the time we don't have to do a formal resection. In case the patient is elderly, the gland is very large, we can do resection as well. And regarding hemostasis, we don't have to worry much. Most of the time, these are granulation tissue which are oozing and they are necrotic. Usually they settle. And we can just keep a catheter rather than just inserting a SPC. So we'll go to the next scenario, Dr. Aditya.
So my question is to
last few scenarios to conclude.
Yeah. So Dr. Keshav sir, how does one prevent, identify and manage rectal communication or fistula formation during abscess drainage or TUR?
It's not very common that you find the rectal injuries during a TUR, but if you want to identify, then if you're very careful, if you see the irrigation fluid coming out through the anal portion, then you should be suspecting something has happened. If you want to be very careful, if you are resecting the floor or areas where you can put a finger inside and see the amount of tissue which you are going to, because if you put a finger into the rectum, you have a better feel of how much tissue you are going to resect. If you have recognized intra-op, then if I am there, I would call a colorectal surgeon to come in to help me, is because management of this will require a diverting colostomy. I would be able to do it, but I think legally it would be better that if a colorectal surgeon is involved in that, we would do a colostomy, leave an SPC and a diverting colostomy and allow the fistula to be healed. And then if it persists, if it heals on its own, it should not be a problem. If it's a small rent, it should heal on its own, but you will not be able to assess it per-operatively because it's an electrical injury. So it could, over a period of time, become more and the fistula could persist. But if it's a small one, if it heals, it's all right. If it does not heal, then when both the diversions are there, then you will have to handle it as a recto-prostatic fistula itself by the perineal route.
Okay, Dr. Girish sir.
So one thing,
yeah,
Aditya.
Shah,
Aditya,
yes,
one
yes,
thing. See, for all practical purposes, this is something like a never event. It should never happen. Does any one of us have any personal experience that it has happened?
Sir, I have shared the image.
Okay.
It does happen.
Okay.
I had one patient.
Yeah.
Okay.
So I would like to say my question for the Dr. Shah sir is, in this case where the abscess was already impending to perforate or drain into the rectum, and we went transurethral, though it was pushing on both the sides, with the sheer pressure of the irrigation fluid itself, some fluid started seeping. Apparently, we had a serious doubt that some fluid had started seeping into the rectum. Now, we have not caused any electrical injury. We have not gone deep and dissected it. So what prosthetic abscesses many times just open in the rectum and they heal off. It's not such a deal. So should one really go with the extensive approach of colostomy and all, or is there a way to wait and watch and do something else?
No, in the scenario that you have explained, when there is no electrical injury and all that, there is definitely a role for a conservative treatment by putting in the catheter, keeping in NPO, taking a general surgical consultation, and putting him on IV fluid. That may work.
So what we did in this case, because we really thought there is something is going in, and we just put the traction, and we kept patient on initially nil oral for a day, and followed by stool softeners, and later we kept catheter for a little longer, almost a week's time, and we removed the catheter and patient recovered without need of much further intervention. Maybe we were lucky enough. This was a scary scenario though. Dr. Chawla.
Aditya, can I contribute?
Sure, please.
Yeah. So one case, there are two cases which I have dealt with. There's a one case is post TURP status. He comes with the obstructive flow again, and this patient is taken for re-TURP, and his TURP phosphatase are irregular, and TURP is done. And 2 weeks after, the patients come with a leak from the rectum. This patient on histopathology was found to have tuberculosis of the prostate. This is the one case I remember, but he didn't leak on table. Other case I remember where when I was called, the catheter has going into the rectum. You can then this inflated, irrigation started, and everything is coming from the rectum. At that point, the colorectal, first the general surgeons were called. They again the finger dilatation and with the guidance catheter place in that. But within 24 hours, we had to take him in for proximal diversion.
So to conclude on this, the rectal injuries which happen because of the electrical current injury, as described by Dr. Keshav sir, one should have extreme caution and involve multidisciplinary approach in terms of diversion, because with the electrical injury or a chronic disease like tuberculosis, they are unlikely to seal off themselves. But a impending prostatic abscess which has just opened into the rectum, and we have not caused any surgical damage or trauma there, may sometime very well respond to conservative treatment of drainage and diet management and hospitalization. Next, Dr. Nitesh. So my question is to Dr. Lalit Shah sir. So in between, if there is a spark in the resectoscope and you think that it can cause extensive damage to your scope, and you have changed the loop and everything, still it is persisting, what is the way ahead?
Then in that scenario, at that particular point in time, then I'll abandon the procedure. That would be better. Or unless until you have a separate set, which I have fortunately, a separate set where everything is different.
So how will you achieve hemostasis then?
You're in the midway.
Usually, see, most of the time, unless until it is a very, very massive bleeding, Foley catheter and traction usually works 99% of the cases, even at whatever stage it is there.
Okay.
And like I said, if we have the availability of a full set of separate scope, another loop, another high frequency cord, you can use that.
So what we conclude here, the instrument failure can actually damage urethra, can have permanent damage to our instrument set itself. So one should really avoid continuing doing procedure with such instruments, and should try to come out with minimal intervention, whatever is needed, and just be out of the procedure.
One more tip for freelancer.
Yes, sir.
Apart from spare cable, and you should have a spare urologist friend.
Yes.
Who can help you in the situation, especially if you are a freelancer.
A friend in need is a friend indeed.
Yes. Always have a friend.
So, question to Dr. Anurag Yadav. What do you, in case of large undermining of the bladder neck or trigone getting undermined, what are the options?
Yeah, if it is like the shown in the picture, It is likely to be extraperitoneal collection of fluid also. To palpate suprapubically, if there is a collection, you leave a catheter and drain suprapubically the extravesical collection. If it is no extravesical collection, then you, of course, try to finish your job quickly. Leave a catheter, it will heal. There is nothing special to be done for this. No repair or anything. No suprapubic.
What will be your method of catheter insertion?
Of course, over a guide wire.
And how many days you keep the catheter in this case?
Maybe a week.
Okay, for a week.
But of course, put your hand on the suprapubic area. If there is a collection, you have to put a little drain there also.
So if it is extra peritoneal collection, you would like it to be drained?
Yes, yes.
Okay. But the way it has gone in, it can always drain back. I mean, because it's a closed space.
It can travel on the sides and come interiorly also.
Okay. Next.
So next scenario we are having, we are giving a bladder was, but there is a large chunk of tissue in the bladder and we cannot evacuate it. So what are the ways to remove it? Dr. Girish?
Girish sir loves to take out long chips. I would like to know how if he can't take it out.
No, I don't see. After becoming older, I don't take those big chips anymore because I can perforate. So after perforations, I stopped taking the big chips. But here, you have to evacuate transurethral. That's the first thing you have to do. So you keep on resecting. You fix them. You take some time. It's just like after HOLAP. How do you take them out if you don't have morcellator? You use a TURP sheath and keep on taking them to smaller and smaller chunks till you need to have a patient.
They keep on moving actually.
I know they keep on moving, but you empty the bladder. You don't keep the bladder very full. If you keep the bladder very full, they keep on moving. You half empty the bladder. You do some maneuvers, some circuses, and fix them, and then resect.
Use of nephroscope with forceps.
Yeah, that's what. If you cannot do it, then you put in a nephroscope, use a forceps to take them out. Or other option is do a suprapubic cystostomy, put an implants and take them out the way you take out stone this thing after TUR, after systolithotity. These are the various ways in which you can take them out.
Dr. Keshav, you want to add anything?
Yeah, there? I have removed more than 70 grams prostate, which was whole up done. The whole tissue was inside. And
it was a demonstration.
Yeah, and then the morcellator did not work. Yeah. So the surgeon went home. Next day, I had to resect, sitting for more than 45 minutes to 1 hour to resect the whole of that tissue bit by bit, and it's a hell of a lot of problem doing it. But you can do it. It takes a lot of effort to do it.
Anyone wants to share any other tips here?
Yeah.
Yeah. Another thing that I just want to add is what happens is that whenever you are doing a TUR in your career, there is an underdoing, then overdoing, and then you come to a mature level. So while overdoing, I was doing about moving of the sheath in the large gland more than 2 loops full. And then I found this trouble. So I realized that you should not take more than 1.5 time of the loop if you are moving the sheath.
You should not make a noodle out of TURP.
Yeah, I have a few comments to make. This usually does not happen because of long loop, because of long piece taken. It happens because of the median lobe. It gets cut from both sides and then goes freely into the bladder. That is the most important usual situation. So first thing is, if it is not coming in the iliac, you try and remove it through the sheath and with the loop. If it is not coming, then you come out with the sheath and the tissue together through the urethra. Again, the tip is here that if it is a very big chunk, it will damage the sphincter if you try to pull it through the urethra. Then you have to cut. You have to bring it into the prostatic fossa and get stuck there. Yeah, and don't try to pull. And then you cut it like a usual prostate. It becomes the part of prostate again. Deliver it back into the prostatic fossa and then cut.
Nitesh, can I make a point?
Yes, sir.
Yeah, I agree with Dr. Yadav. I have a similar sort of experience. And till last, I keep that particular chunk there. And at the end, generally, I come with this, engaging it into the loop and come along with the sheath. And most of the time, it works if it is a reasonably okay size. If it's too large, then it's a different thing. You need to make it in a smaller pieces. But this technique which he explained that I have used in couple of time, and it works very well.
So
it happens in morcellation. While doing morcellation in HOLEP also, if you bring it to the fossa and apply some coagulation, it sticks to the fossa actually. Then you can make multiple chips out of it and take it out.
Yeah, that's the only thing is, if you have engaged this this our tissue piece, which is usually from the median lobe or intravesical projection, if once you have engaged with the loop and the sectors of sheath, don't cut or use energy when you are in the bladder. Bring it as close to the bladder neck in the fossa as possible. Otherwise, you will injury the thermal injury to the bladder wall will happen. You have to cut into a number of pieces before it is manageable enough to come out through your sectors of sheath.
So to conclude, if it is a small and reasonable size, then probably we can engage in the loop and bring it out through the sheath, or we can bring entire TUR sheath out through the urethra. Most of the time it will come out. In case if it is fairly large, then probably we have to cut inside. It is preferable to cut inside the prosthetic fossa rather than in bladder. And to minimize the movement of the chunk, we can keep the bladder empty so that the tissue does not move much. So we'll go to the next scenario, Dr. Aditya.
So my question is to Dr. Kamath sir. How does one prevent and manage a bubble burst?
You mean the explosion inside the bladder?
Explosion, yes, yes, bubble explosion. First of all, if we can prevent formation of bubbles, because that is the first reason of presence of bubbles itself. How does one prevent generation of bubbles, and if the bubbles are there, avoiding explosion, and if it happens, how does one go about it?
Aditya.
Emptying the bladder
Aditya.
more quick. If you keep
Aditya.
Yes, sir. Just Kamath, let Kamath sir finish. Yes, sir.
Emptying the bladder more frequently, every 15 or 20 minutes, you keep evacuating the amount of air, the gas that is formed inside the bladder. That is the only way you can prevent. And see that there are no sparks. The same electrical problems, that is no sparks or loose connections between the loop and the frequency cable, and no broken loop at the end of the I mean, you have to be careful to see that the loop is never broken. I think the most effective thing is to evacuate the bladder every 15-20 minutes, the amount of gas that is there.
So, Girish sir?
No, I don't. I thought Dr. Keshavmurthy had an experience. That's why I thought.
I have had three patients who have had this. Two of them done by me, one of them done by my resident. One of them was a bladder tumor in the vault. When I was resecting, I could make out that there was a sound which gave way and the abdomen started. So we had to repair it. Second time was when we are doing TUR, especially in the anterior part, in the bladder neck region, you will find this air bubbles coming close to that. When you ignite at that point of time, it will give way. So I have had three cases which have had air explosions like this.
So does patient position helps in spontaneous evacuation of bubbles through the exit of TUR sheath?
No, they say that when you're doing a prostate, if you tilt the table, the bubbles go into the bladder, so it doesn't come more towards the prostatic fossa where you're resecting. That is one change of position which you can do. But otherwise, you're emptying the bladder more frequently than, and getting all those bubbles out is much better than. And when you find those bubbles, don't resect. Unless you empty, don't resect.
I have just one input in this, like as temperature of the saline also plays very important role in terms of bubble generation. We have to keep our saline temperature as close to the body temperature. So 37-38 degree is the ideal temperature for saline, but normal OT temperatures are 20. The colder the saline, the more bubble formation is there. So that is one thing. And all explosions don't end up in bladder perforation, especially in case of TURP. So keeping bladder half filled, even with the explosion, we may luckily get away from major complication. Dr. Nitesh, I guess. Nitesh. Okay. So next, I'll ask if already bladder perforation has happened, maybe because of bubble burst or we don't know, the abdomen started distending, bladder perforation is there. So intraperitoneal versus extraperitoneal, how to differentiate and how to manage? Dr. Chawla, sir.
Hello.
Yes, sir. Yes.
I think it all will depend upon the size of perforation if it's intraperitoneal. Now, if you have finished your section, evacuated all the chips, and if the perforation is small, probably you can just put a catheter, and with a slow irrigation you can come out. But the only thing is extraperitoneal will not lead any change in the management unless until you have a lower abdominal full bloated with the fluid which is extracted from the bladder perforation. Intraperitoneal, I think you need to take a call depending upon the size, whether you need to go and explore it and close it by opening with a small mini cystotomy incision. Because all will depend upon what stage and with the size of perforation, because you are going to give this patient irrigation which is going to drain it, okay, but in the presence of a small obstruction for a transient time also, with any clot or any residual fragment or any ischemic tissue which is going, it is going to add up again to the opening of this perforation which is collapsed, and it will open again and go to that. It will all depend upon that situation only.
So, Dr. Girish, in case we don't have, obvious bladder injury seen, and we still suspect the fluid is in the peritoneum, what should be? Is putting a peritoneal drain itself is enough? On endoscopy, we don't really see, any bladder rent or anything.
And why should there be a fluid collection in the peritoneum?
Yeah, because when there is with excessive pressure, when the extraperitoneal fluid collection is there, at some point the peritoneum gives way and it allows it get drained in the peritoneum.
Usually, as long as there is no discrepancy between what goes in and what comes out, there is no problem. Second thing is you give bladder wash, and once everything comes out, there is no problem. Third thing is, in case there is no gross abdominal distension, and when you or if you are in doubt, you put a needle and see whether there is a gross collection of fluid in the peritoneum. If it is not there, and if you can get an intraoperative ultrasound, if can manage, that's even better. So if these criteria are not met, then you don't have to do anything. Just put a catheter and come out.
No, but if there is significant fluid is there, and we can see in this image, then we have drained it once. So should we just leave a peritoneal drainage tube, small, drain, and leave a catheter if inflow outflow is okay, Dr. Chawla?
Just to add, I just often I remembered this is a similar scenario, but here I like to say intraperitoneal perforations are very rare. Probably you have given theoretical, but I just remembered one article where the surgeons have gone in laparoscopically and evacuated all the chips and closed it also. That case I remember now. Yeah. Okay, again, so it's all. You see, the question here is even when you are not sure about the perforation, which in collapsed bladder is very difficult, you have to distend it to see. And sometimes you don't have a well-defined margin where it is going. It is going. Everything is going into the peritoneal cavity. Then peritoneal cavity is big. You don't know where the fluid is going.
But sir, with experience, if you like you have done the procedure yourself, unless your resident has done it, you have never been into the bladder. So wow, there is no as such reason for
no. But injury. Again, what I'll say is this scenario is more suited to TRBT than to TRP.
Right.
Yeah.
So it has happened at least twice with me in terms of HOLEP. The extra peritoneal collection seeping into the peritoneum. Almost 3 liter fluid we drained from peritoneum. and we could not see any bladder because vision was generally very clear. There was no issue with the vision. There was no bladder rent. We just put a peritoneal drain and we kept a catheter and patient resolved well within 48 hours.
Yeah, that's why I quoted the one article where they have gone laparoscopically, evacuated all the chips and managed the situation. Yeah.
Aditya, I'll just like to put one clinical scenario for the extraperitoneal rupture of the bladder perforation. See, like when a diabetic patient, little obese with retention catheter, we took it for the TURP. We put in with the visual obturator, we go into the bladder. Then we come out, take out the visual obturator and put the working element and start thinking about starting the thing. At the same point only, with the tip of the sheath, there was a 1 centimeter bladder perforation lateral to right ureteric orifice. What should you do? This has happened with me. What should you do? You proceed, you abandon, what do you do?
Can you say again, sir? Can you say again the situation?
Yeah. Sir, a 65-year-old man, diabetic, obese, retention catheter for TURP. So normally when you want to do a TURP who is on catheter, you do the sheath with the visual obturator, go into the bladder. Once you reach to the bladder, you remove the visual obturator, you put your working element and then you start working up the things. So the moment I have put the working element, I could see that my tip of the sheath has already created a bladder perforation of about tip size, that is about 1 centimeter approximately, on right side of the ureteric orifice. What should I do? Should I have continued or put in the catheter and come back?
Again, sir, you are talking about a full thickness perforation where fat is seen.
Yeah, full thickness perforation.
Yeah.
Extraperitoneal.
Yeah, so basic simple rule in TURP is any deep perforation, whether it's at the capsule, bladder neck and prostate junction or inside the bladder, you have to abandon the procedure and come out after securing hemostasis. Yeah.
No, it is not a hemostasis. There is no bleeding or nothing like that. It is a bladder perforation.
Yes. Your bladder will see what happens is in the TURP, when you are using a continuous rectoscope, your bladder remains all the time full. So where will this fluid go if it is a deep perforation?
Extraperitoneally.
Extraperitoneally, and we know that we in a gland which needs section of 60 minutes with the flow hydrostatic pressure at 60 centimeter, you have.
It's not a very large gland. It's about 40-gram gland.
No, sir. Average we are talking. We are talking.
Can I answer?
Yeah.
I think if it is not a very large prostate, you carefully go ahead and you keep on assessing the situation. In case there is a distension of abdomen or something, at that point you have to stop the procedure. Otherwise, since you're quite pretty sure that it is in the somewhere near the ureteric orifice in the extraperitoneal, it's just like undermining the bladder that we discussed previously. The moment we undermine the bladder, we don't stop the surgery.
No, Girish, there is a difference between undermining the bladder and deep perforation. Deep perforation means full thickness perforation where we are surrounding perivesical fat is seen. That are not the situation where we should go ahead.
No, the surgeon is confident that it is an extraperitoneal perforation. And it's not
it's not the question of extraperitoneal or intraperitoneal. The question here is a perforation is a perforation which leads to accession of the fluid. So where will this fluid go? It has to accessate. It will.
You have a choice.
Anyway, probably what I would do I would go ahead with the surgery.
Best is
taking care.
I would abandon.
Sir, I think we'll not have a consensus.
No.
Then
I'll just tell me what I did. See, in few years ago, there used to be a controlled bladder perforation for lower ureteric stone. There used to be paper. They say that you perforate the bladder, go into extravesical space, do the ureterolithotomy by incising the ureter, take out the stone, put the catheter for 7 days, and everything becomes fine. So that particular thing came in my mind at time. So what I did was I continued with the TURP, but what I was doing was I was taking only 1 or 2 cuts and emptying the bladder, and all the time monitoring that the suprapubic area is not getting distended, abdomen is not getting distended, and the open trolley was all ready. And fortunately, I could get away with it.
Sir, I think keeping a SPC is a good option in this situation. It will keep blood pressures low and reduce the extravasation in such scenario.
Could be.
So, sir, next situation is the bladder neck contracture. What is the ideal location of cuts and cold cut versus electrical energy? Dr. Kamath, sir.
There is no consensus.
Okay. What is
Whatever
so? I
we
think.
do, okay. There is
I think anything is good enough to open the area is, I think,
3
acceptable.
o'clock, 6 o'clock, all round, 3 cuts, 2 cuts, 1 cut, 2 cuts, cold cut, Collins's knife, laser, everything is fine. Restricture is quite common. Recontracture.
And any special role of steroids, mitomycin?
Nothing.
If anyone differs quickly, can take a option.
It's
Okay.
the most difficult situation to deal with, and the patient will eat away. I mean, your peace. You will keep on coming.
Okay. Okay. Next scenario, Dr. Nitesh.
Aditya, how many scenarios are left?
Just, I think we'll just take quickly one by one. Okay. Post-operative glycine toxicity and sudden blindness. Any experience? Any tips to tackle it?
No,
Zero experience.
Okay.
Nearest, you have not to tackle it. You have to send a consult to the ophthalmologist. Usually say 99% it is reversible. So it is all according to the ophthalmologist's opinion you have to pursue. And whatever findings of fundus and everything may be normal. But this is a sign of glycine toxicity absorption.
Anything additional, Dr. Nitesh? You have put this scenario, I guess.
Aditya, I think we are exceeding the resection time.
Yes, already, sir. We are 4 hours into it. TUR syndrome, so much we talk. Is it truly such a big concern in 2020? Please, quick comments, Dr. Keshavmurthy, sir.
No, the incidences come down, but you cannot tell that it's not there at all. You have to be careful and see that you will prevent these things. It's not that it is still less than 1%, but there is 0.4% incidence of still TUR syndrome being reported. So in 2020, it does not made a change. It can happen, but you can prevent it and you can recognize it, you can treat it. So it can be.
So when do you recommend sending an intraoperative ABG to check sodium level?
The first thing you have to see is the anesthetist has to monitor, see if the patient is having hypertension and then bradycardia. That is the time you should send sodium. If the patient starts his BP to go up and he starts having bradycardia, you should tell the anesthetist, send his serum sodium, ask him to give a furosemide.
And confusion in that final analysis, the patient's sensorium becomes altered without narcotics. That's the time.
Most commonly, anesthetist will give his spinal, go for a coffee, and give sedation to patient. So next,
I think what is to be when patient in the spinal, when you see his legs starts moving and patient feels he's agitated, he's taking off his all the sheets or cover sheets which he has anesthesia has put over his side, and at the same time you look at the monitor, you have seen the BP going up. Bradycardia may happen little late. So that are the things which are pointed towards that probably this is going into TURP syndrome. But again, it's a combination of symptom and signs both. You have to be very careful about.
Okay, so quick comments of Dr. Yadav and Dr. Girish. After that, the type of catheter, size of catheter, and duration of catheter, and what size of balloon you inflate.
Comment about the hyponatremia or catheter?
No, normal catheterization after that.
Yeah, I keep a 20 size catheter, 3-way catheter, and balloon I inflate to 40 cc, and I always put traction by the gauze knot method.
Dr. Girish, any impact of size of balloon, size of catheter, and duration of catheterization in your opinion?
Probably no. I think it's very difficult to answer that question. I think we use the smallest possible catheter. I use 20. Many people use 18. Some use 22. I think no one knows whether it makes any difference. balloon, again, I put 40. There are many people who put only 30 and they got good results with that also. Role of SPC, only if we find that there is a lot of problem, then I put SPC, otherwise no. Probably there is no answer to this question at all.
But if you have resected a 90-gram gland, how would a 30 cc balloon will simply slip into the fossa only?
Maybe yes.
Yeah, actually, no. As long as 30 or 40, I put 40 cc. Usually I put 40 cc. And almost always I don't see there is any problem. See, at the end, we don't know where it is sitting. At the bladder neck or whether it has come to the fossa, unless you do a fluoroscopy or ultrasound, we don't know where it is sitting. Who knows? Many times the traction that I put might not be at the bladder neck at all. I have no idea.
Aditya, if you are
Sir, I would like to make a comment, sir. Anytime if you have a doubt, you can put a finger into the rectum and you can easily realize and recognize that your balloon has slipped into the fossa. So it is almost very easy to know where exactly you have put clinically at the end.
Because
And
whenever balloon slips into the fossa, the bleeding increases. Many times we have seen, we have just pulled and
we must give a message, and we must have effort to put the balloon only in the bladder, to compress the bladder neck, rather than any time considering to put it into the fossa. That is my view, my experience.
The general recommendation is that depending on the amount of tissue that you have removed,
the size of balloon.
Size of the balloon should be there. So normally, my preference is from 30 to 60 cc.
Okay.
But
So
the thing is that it should be in the bladder.
Yeah, of course.
Never it
naturally.
should be in the fossa, because it doesn't serve any purpose in the fossa. Our aim is not to allow and trickle the blood into the fossa to come into the bladder and lead to the clot retention of the catheter. That is one of the reason. And second thing is definitely it compresses some major vessels entering into the fossa at the bladder neck. But otherwise, the basic aim is not to allow the blood to trickle from the fossa to the bladder and cause the clot retention in the catheter and subsequent issues. We must keep the bladder as well as the fossa, bladder collapsed, and fossa to also of a minimum pressure to get collapse.
We'll go to the next scenario, traction. Keshav, sir, do you routinely use traction?
I routinely give traction, and my preferred way of putting traction is onto the abdomen. For the simple reason, you can allow the patient to move his lower limbs. If you put a traction to one of the limbs, if he flexes it, your traction effect is gone. So we give traction, but it's put onto the abdomen.
I think Dr. Yadav, you already said you give a gauge traction salivary.
Yes, I gave gauge traction and I never regretted. There have been reports of necrosis of the glands or the prepuce, but I have never found it.
How long do you keep that gauge?
I mean, I do my cases in the evening, so I have to remove it in the next morning. So staff removes it 6 o'clock in the morning. My cases finish in the evening, so it is almost 10 to 12 hours.
Gauze traction also helps in stopping bleeding of the meatus if you have given the incision.
It closes the area between the two things, the balloon there and the gauze there, and if the blood flow fills in the prostatic fossa as well as in the urethra, and the patient's clothes are not soiled.
So on thigh versus abdominal traction.
Aditya, may I just speak? My experience with the salivary slab had been different in the sense that it has caused a meatal necrosis. So I have stopped using salivary slab because that is recommended. It should not be used more than say 20 minutes or half an hour or something like that. So I use is the normal traction on the thighs.
Sir, but I think it's all depends upon how much traction is being put. Many times we are just leaving just gentle traction. It doesn't make much of a difference actually.
Maybe that I might have put a more traction in that particular time in that case has happened. So when it has happened once, you burn your finger, then I'm not using that.
Because sir, while putting traction, once the idea of traction is set in the mind that I put only gauze, then we decide how much traction is the put and we follow the same method of traction. If we need more traction, better to put on abdomen with much of traction. Less traction, I think it's okay. I think next, Dr. Nitesh. Thigh versus abdomen, is there a... Okay, bleeding, done. Okay, after, once the surgery is over, suddenly the bleeding is more. What is to be done? So one reason could be the waning of spinal effect. Other increase could be increase of blood pressure. and maybe a secondary sputter. How does one differentiate and how does one go about it? I think Dr. Chawla sir, can you please?
So one thing usually I don't use traction. So if this is a scenario where the patient has the color change in the effluent, which is not acceptable, this is the scenario where our residents, without asking only, will use the traction and increase the irrigation and see. But again, it will be consciously watched how much bottles are being used over a period of 1 hour. So let us assume this, the color which you are showing, it is not with the increased irrigation and with traction is not changing to near normal. We'll wait it with the increased irrigation over a period of 1 or 2 hours, depending upon how much post-operative period has elapsed. Supposing this is continued and the patient is still under spinal, this will be a candidate which will go in and have a look. If it is already weaned off, then probably we'll wait for a little more time to settle it on its own, and probably will not wait for hemodynamic changes to happen, that the patient go into the hypotension and the bleeding stop on its own, probably. So this will be a case which will need a good post-operative monitoring.
So I think I'll just quickly, take few points out of this bleeding scenario because it is very common. It can happen. One thing is the color of the effluent. If it is bright red, if it looks like arterial, it comes in a spurt, suddenly it clears and suddenly it starts becoming red. If it despite best of irrigation and traction, patient needs to be taken back again and we need to do something about it. Other thing, we have to check for the blood pressure. If the blood pressure is higher, 160, 170, we need to control the blood pressure. It has happened a couple of times with me that blood pressure suddenly patient became agitated in post-operative period and BP was high. We took him again in spinal given, the BP went down, we could not even find the bleeder. So the blood pressure has to be controlled. Of course, as you are keeping traction as a spare option, that's a very good thing. You have something to offer once such situation arises. And anything which is not maintained in peri-operative period, we should not leave it for the night to call us back and the patient to OT again. So I guess next.
Yeah, I have to make one
Yes,
point.
yes, Dr. Yadav.
Yeah, most of the times the bleeding is venous and it is from the sinuses, and that is helped by the traction. But sometimes it is not. Even it increases by traction. So one thing I found helpful is to keep the urine bag on the patient's bed or even on his abdomen rather than making it hanging. We know that the sinuses start bleeding more when there is a low pressure or when there is a suction effect. So many times when you hang the bag down, there is a suction effect and the bleeding is more. You know that during resection, when you empty the bladder, you find pure blood dripping. When you start resection, you don't find any bleeding. Again, when you empty or you do ALEC, then there is a bleeding. So this is a venous bleeding, and it is helped by keeping the urine bag on the patient's abdomen or on the bed, not allow it to hang. You try it, then you will know.
Good points. Yeah, Dr. Nitesh, next, I guess.
So you have shifted the patient in recovery and you notice the catheter have come out and you're not able to insert it back again. What do you do? Lalit sir. Probably
you will be able to put in again.
Back.
Sir, there is a supposed trigon is undermined and you can't enter.
So it all depends at what time it is there. If say for example small gland is there and it is already more than 24 hours, probably I'll wait for patient to void if there is not significant bleeding.
Sir, immediate post-op.
Immediate post-op, then of course you have to go back and put the catheter again.
Can one try on catheter guide?
That
the rod,
no, I am so afraid I do not have. I am afraid I don't do that. I don't have.
You don't have.
Anyone want?
Again, at time you can ask your assistant to put a finger into the rectal fossa, rectum, and lift up the prostatic fossa, and that maneuver works. But if it doesn't work, then definitely we have to...
See that here the question occurs is whether to shift the patient to OT or not. That is in the mind of the patient. So you would not believe that I had done one bedside cystoscopic, put in the guide wire and threaded it over there.
That
So
is
as to
next
come out
option.
for
Now,
this.
wherever you do, if the patient is still having an effect and you don't want to take the patient inside the OT and your room is having a comfortable space, you can definitely do a
Yeah.
on.
That is what I'm saying. Rather than doing blind, I would. My preference is to do it under
not
vision.
to do it blind.
Lalit Shah, sir, you own the OT, you own the room also. Why you did it in the room?
No, because the patient say I did not want the patient to understand that there is some problem and
Think
they're
about
shifting it back again, which basically is not a big problem. See, for patient side,
But
it is a different thing.
this is possible very much. Sometimes
Yeah.
poor quality catheter, the bulb, if you have inflated 40, 50 cc,
sometimes it can leak. Yeah.
No, many times actually this happens because many times actually this happens when the sister actually connects the irrigation
to the drain, that one.
A new sister consultancy inserts that irrigation channel there.
Yeah, next, I guess, Nitesh.
Quick fire. This is the last slide, so we are coming to the end. So we'll just ask each panelist. There are 7 questions. We'll ask everyone. We'll start with Keshav, sir. How long do you give antibiotic post-op and what is your preferred drug?
Cefuroxime is my preferred drug, 3 days. The time we remove catheter, we send him home, we stop antibiotics.
Lalit sir, is there any role of 5-ARI for decreasing post-op hematuria?
No.
Okay. With any of this point, please let us know. Anyone is giving 5-ARI post-op in all cases of TURP?
No.
So the next is, when do you restart antiplatelet or anticoagulation post TURP? Dr. Girish?
About 3 to 5 days. Usually 3 to 5 days. That is a thumb rule. But in case the hematuria continues, I'll wait.
The hematuria to stop in case the patient is having some hematuria?
No. If the patient has hematuria, then I will not start. But at the same time, I have to take the opinion of cardiologist also, how long it is safe to stop. Because if they say you start early, then they have to take, the cardiologist will usually decrease the anticoagulant, but start early. But given a choice, I usually start, if there's not much of hematuria, about 3 days.
Did anyone ever face any problem happening
Dr.
in a
Yadav,
patient because of stoppage of
always in
anticoagulant?
your
Yes.
Yeah.
I have had a death.
Okay.
I have had a pulmonary embolism.
Yeah, I had a death. That's why I'm so scared.
So would you prefer, heparin, enoxaparin for preventing? Okay.
Yeah, heparin.
Dr. Yadav, do you add laxative always post TURP?
Always.
For how many days do you give?
Full month.
For 1 month. Chawla sir, how do you treat early post-op dysuria?
Hello.
Arun, yes, sir?
Early post-operative dysuria. What is the management, your management? I guess there's some issue.
Hello, Chawla sir.
Arun sir? Okay, we'll ask Kamath sir, what is your management?
I will see whether there is infection. If there is infection, I treat it. Otherwise, I will observe it. And I tend to give alkalizer something.
Sir, alkalizer and pyridium also helps a lot.
Yeah.
And is there any role of anticholinergic in post of increased frequency? Chawla sir is there? Arun sir, you are there?
Yeah, I can hear your voice in breaking way.
Okay, I think some internet issue is there, sir. Any role of anticholinergic in your experience, sir, post-operative?
You are asking about you are asking about
anticholinergic.
This is when antimuscarinic
post-operative.
No, when with the catheter in situ or with the catheter removed.
Sir, catheter is removed. Patient is still complaining high frequency. subsequent to the
So,
TURP.
what is to be understood is if you have bladder spasm in the presence of catheter, this is the one indication where you need to put a antimuscarinic, and probably these are the patients where you keep the catheter for a longer period so that antimuscarinic gets acts and the bladder spasms are reduced. In the post-operatively, all depend. See, when you have done a TURP, you are assessing this patient for a symptom. So you remove the catheter before discharging. You are going to do one ultrasound. You are going to check his fluoride. You are going to check his post-void nasal urine and his symptom post-operatively. So depending upon that, if the urge symptoms predominate or there was no relief in the urge urgency subset scoring of that symptoms, probably he will be the candidate who will need for some duration anti-muscarinic. And usually not anti-muscarinic, I usually prefer mirabegron in this patient unless until patient is having a issue related to hypertension which is not controlled, which usually will not be the scenario because you have already done assessment.
Okay, and the last question we'll ask Anil sir, when do you remove catheter?
Ask everyone. You ask everyone.
Everyone can answer.
So,
I kept it for 2 full days, and third post-operative day means if I have done on Monday, I usually take it out on the Thursday morning.
No, sir. I'm not able to finish the logging in. It is showing.
I remember
me
the second post-op
that
day if the urine is clear.
Third post-op day. I remove the catheter on the third post-op day.
Second post-op day if the urine is clear. Third post-op day if the gland was grade 3.
2 to 4 days depending on the size of the gland.
Yeah.
Why larger gland should need longer catheterization, sir?
I don't know. Maybe there is possibility of bleeding is more or something like that.
In fact, the larger gland will leave larger fossa. There is less chance of, again, obstruction and retention.
But our experience had been that somehow the other they have not been able to void, and you have to put in the catheter again. They had been complaining of something or the other. So over a period of time, we realized that keeping it for the larger gland up to 3 or 4 days is good enough.
Okay. So finally, with this, we conclude our session. I think it was a little bit long and exhaustive.
4 hours, 10 minutes.
I would like to thank Dr. Monoral from Bangladesh, Dr. Karthikeyan, Dr. Anant Kamath, and Dr. Girish for sharing videos and images to make this session fruitful. I would like to ask Dr. Anil to give a concluding remark before we conclude.
So I will not take much time, Nitesh, as usual, because it is quite exhaustive this session, and you people logged in since almost 4:45, so you almost 4.5 hours. So thank you all expert panelists for the answering all these really tricky situations and very important conditions to tackle, and you have enlightened all of us, and specifically those juniors watching this webinar very now since last 4 hours very much. And Dr. Sabnis was there from the very beginning, so I would like to request Dr. Sabnis to unmute himself and give a couple of comments, sir.
Oh, thank you.
So he was since there from the very beginning. At 5 o'clock, he's there with us on the and almost chat box. He has made a large amount of comments. Please, sir.
Yes. So thank you, Adil, for asking me the comment. It is a very exhaustive session, but I really enjoyed because every scenario which you have thought of is of a very practical relevance. In fact, as Ramesh also pointed out in the chat box, that these are the scenarios which we ask in the exam. So we expect that every resident should know all these scenarios. And even the consultant's point of view, those who are in practice also, we share these scenarios with each other. There are some scenarios which are discussed, which I have also not encountered. So I have learned a lot from this exhaustive session. So I think you have put in a huge amount of efforts. I think those efforts were very much visible in last 4 hours discussion. Every aspect you really thought of, and the faculty has done a fantastic job. I think I must give credit to all the faculties that every aspect they have answered and they have justified their answer. So I think the credit certainly goes to them also, that this 4 hours of, see, it is difficult for anybody to log in and continue interest in the discussion, listening to the discussion for 4 hours. But I think it is because of the quality of the content which people have logged in. I also enjoyed. I never thought of logging out and then doing something, because the way the discussion was going on is very practical related and very interesting. So I think full marks to the organizers and full marks to the faculty. Thank you very much.
Thank you, Dr. Sabnis, and big hand to Aditya and Nitesh. Once again, you have done really fantastic job collecting these many scenarios and putting it to in a very proper way. And great thanks to the all panelists. And quick comment from the all panelists. One comment, Arun Chawla sir. Though it is quite late, sir, please unmute and have a last comment on this session, sir. Lalit sir, we start from you.
Oh, this was wonderful, wonderful.
We hope that you enjoyed like we did.
Yeah, sure, definitely.
Right.
No other word.
Sir.
Yeah, it was thanks Nitesh, Aditya, Anil. It was a good session. We learned some tips also from the other panelists, because you will not find so many scenarios at a point of time.
And most importantly, sir, that with the pace you people were discussing and these people were allowing, that is was very interesting. And without much of a controversy or very big and high pitched talk, you people conveyed points of very much very effectively. So Anurag sir, your last comment, sir.
Yeah, thank you Nitesh and thank you Aditya. I enjoyed a lot and learned a lot.
Yeah. Anant sir and Girish sir.
Yeah, I learned more than what I gained. Gave. I learned more.
Thank you, sir.
Thank you very much. All of us learned. It was a learning experience for all of us.
Right.
I think
Chawla sir, you are there.
There is, I think, some issue with the audio.
Okay, perfect. So we again, once again, thank you all very much. And with that, we are at the end of 6th edition of the Troubleshoot. Any point you want to convey, Nitesh and Aditya?
Sir, only thing I want to say.
Anil, just
Yes,
one
sir.
point, and
Sir.
this is the 4 hours webinar, which I think all residents must save, and they should see again and again.
Perfect,
This will
sir.
cover
Perfect.
everything about
Everything,
the TURP.
every single thing covered.
Everything. So I think this is the 4 hours exhaustive session is worth saving and watching
Absolutely.
again and again.
They cannot miss
I'm
any
going to tell
answer.
our
If they listen this carefully,
Yes.
they will not definitely miss any answer.
I'm going to tell
given
our
the
residents that you save this and then keep watching whenever you have time. That is enough for you
Thank
to
you.
answer and you practice anything related to TURP.
Thank
I would
you.
like to take the same point of Dr. Sabnis sir further. Kindly, everybody, please encourage your residents to join in on Facebook on this Alto group. And I would still request all my seniors, my teachers, kindly come on the platform, share on your experience on different scenarios. We'll have a lot of opportunities to learn from you. And this was a special opportunity. Everybody is my teacher here. And I got a chance to ask questions to my teacher, so I didn't miss that. Thank you so much.
So thank you very much and goodbye and good night to all.
Okay, bye-bye, everyone.
Bye.
Thank you. Good night.
Thank you. Good night.